Good morning. Welcome to the last week of class. Today is class 7. We have our final skills today. So the last 3 skills that we have to learn, and the rest of the class will be practice. You have quite a bit of practice time built into today. Nothing that we're learning today is, I'm sorry, there's 4 skills today, but nothing, no, 3, because we've already covered range of motion, shoulder. Nothing that we're learning today is overly difficult. Some of it is kind of repeats of what we've already learned. We will learn some new equipment today, some new supplies. And that's going to take up the majority of my lecture, is explaining what catheters are, how they work, what the different drainage bags are, triangular graduate containers, those types of things. Bedpan cleaners, things like that. So a lot of today is about supplies and equipment and processes, but we need to know those to be able to do the skills. Okay? All right. You had chapters 8 and 9 over the weekend. Let me go ahead and get your scores. Veronica?
I got you wrong.
For both?
For both, yes.
Thank you. Deslin? Oh,
1 second.
sure. 188 and 189.
Zero for 188
Okay.
and 0 for chapter 9.
Very good. Hannah?
1 and then 2.
Thank you. Bianca? Sylvia?
0 for 188 and 1 for 189.
Thank you. Chelsea? Okay, so I need 4 through 7 then.
4 I got 0. 5 I got 0. 6 I got 1 off. And 7 I got 0.
Thank you. Nevea? Cynthia?
1 and 0.
Thank you. Okay.
Um,
Yes.
I always ask that.
No, and that was my next question. Are there any questions on what you missed? So I always ask too.
Okay, I put number 9 in chapter 9 test.
Okay, let me pull out my book. So this is on page 189, number 9. Okay.
189. Okay, so what I don't know if I told you the way I do it. I answer the questions first before reading. Then I read and then I try it again and then I go to the last page.
Okay,
So that's the way I do it.
that's fine.
Okay, so I don't know, but it was number 9. The following is true regarding prosthesis, and I put number 1, letter A.
Okay,
Every prosthesis must be soaked with cleaning solutions.
okay,
And the answer was C, but I didn't find it. I don't know.
okay.
I don't know if I didn't read it okay or what.
So let's talk about what a prosthesis is. So a prosthesis or prosthetic is something external that is used to replace a body part. So a denture is actually a prosthetic. It replaces teeth. Some people may have a artificial leg. That's a prosthetic. So a prosthetic or a prosthesis is an object or an item used to replace a natural body part. Good? Okay. So you might have a prosthetic eye, right? If somebody lost an eye, they may have something that they put in to resemble an eye. You might have a prosthetic finger that somebody, puts on and straps on to take the place of a finger that was lost. So we don't want to soak those items in antiseptic solutions. So an antiseptic solution would be like a bleach solution, because these are items that are going to be, how do I put this?
Dissolve it or something
Yeah, we don't want, yeah, they're made out of different materials. So metal and resin and all different types of materials to create this. And if we soak those in some sort of a strong solution, we don't know what that solution is going to do to that prosthetic. So how do we care for prosthetics? We would follow the care plan. The care plan will tell us what to do, whether to wipe it down with a hand wipe or, a antiseptic wipe, or just wipe with mild soap and water or something like that. The care plan is going to tell you how to clean that prosthetic based on its composition, its use, all of that. So we don't make the decision. Remember I said on the state exam that we don't decide anything? That if it's a principle, something we should know, it's on the back wall. We've already learned it. So did we learn in class to soak anything in an antiseptic solution? No. So that means if we pick A, we didn't follow the care plan. We made an independent decision. Remember I said a couple weeks ago that making independent decisions your brain will trick you, and you'll make an independent decision without even realizing that you've done it. This is an example of that. Does that make sense? Okay. So if it said per the care plan, that would have been the right answer, because the answer is telling us the care plan told us to do it, so we would do it. So if the care plan doesn't tell us to do something, or the nurse doesn't assign us to do something, or it's not a basic nursing principle on the back wall that we've learned, it's your brain. Make sense? Make sense?
Yeah, that the patient can do whatever they want with their own stuff.
The patient can do whatever they want, period. Yeah, period. That it's their body. It's their stuff. So let me ask you a question. I'm going to make it personal for you. Do you have a car? Okay. Is it your car? Okay. So, okay. So you get to decide what to do with your car, right? So if you want to put those little eyelash things on your headlights, right, that's your decision. Now, I might think those are the most ridiculous things in the world. I might think that they interfere with the proper workings of the headlights. I might think a million things. Do I have the right to force you to take those off? Why? Why? It's your car. Yeah, you're going to tell me in no uncertain terms where to go with my opinion, right? Because that's all it is. Exactly. Very good. Very good. So what is the difference between you in this classroom, you out in your car, or you in a healthcare setting? When are you willing to give up your rights?
You can't do it no more, I guess.
Never.
Never?
You are never willing to give up your rights. So when we assume that we have power over patients, that they have to do what we tell them to do, that is the wrong mindset. You're no longer helping. You are now the warden. You have taken their rights away, and it's just as limiting as if we had put them in jail. Does that make sense? So when I say, when I correct you, right, when you said they can do whatever they want with their stuff, and I said they can do whatever they want, period, it's because of that. Now, if what they want to do is dangerous, puts them at risk, is contrary to facility procedures or policies, or doesn't respect others in the environment, we don't solve that problem. Who does? The nurse. Absolutely. Absolutely. So if the patient says, I don't want to wear my prosthetic, we went over this in class last week. Okay. So if the care plan tells us they have a prosthetic, we follow the care plan, or we encourage the patient to follow the care plan, or if they don't do that, then what do we do? What's our number 3? Tell the nurse. Yep. Remember, we already have a workflow for that. Okay, so we follow the care plan, or we encourage the patient to follow the care plan, or we tell the nurse, in that order. So we now know, without looking at the question, how to answer this question. Okay, so the question says, which of the following statements is true regarding a prosthesis? A, every prosthesis must be soaked in a cleaning solution daily. B, stump socks should not be used to avoid slipping. C, patients may decide not to wear a prosthesis daily. Or D, phantom pain does not need to be reported. So let's look at each one. A would only be correct, soaking it in an antiseptic solution daily, if it's on the care plan. It doesn't say anything about care plan. Get rid of that answer. B, stump socks should not be used to avoid slipping. Well, the use of stump socks would be indicated on the care plan. This answer doesn't have anything about so we get rid of that answer. Okay. C, patients may decide not to wear a prosthesis daily. Are patients allowed to decide?
Yes.
So that's probably the right answer, but let's keep going. See if there's a better one. D is phantom pain does not need to be reported. Now this goes right back to class 1, hour 1. CNAs report everything. So D cannot be right. Good? Make sense? So this was a tricky question. And if I'd given you this question in chapter 1, it probably would have been, you would have been like, I don't know how to answer this. I gave this to you in chapter 9, the way that I wrote this question. Guys, these are not just random questions, right? Every single question that I give you, whether it's here on the game show tomorrow, on the practice test, and our questions of the day in the framework that I just published, every question was written by me in a very specific way. Every word has a function. And those words are designed to test your reasoning ability, your ability to adhere to the care plan, the whole care plan, and nothing but the care plan, your ability to not make independent decisions. These questions look pretty simple on the face, but there's a whole lot of psychology in the way the answers are placed, the wording choice, and this reflects exactly how the state exams are going to be presented. Okay? So it's not that I just sit down and, throw out a couple words and create a question for you. There is a lot of work that goes into this, and it's designed specifically to prepare you, to give you the best chance of passing the state exam. Good. And if you want to learn more, that framework that I just published will help you. It'll help you answer questions like this, because you would look at that after knowing the framework and go, okay, hold up. We got to evaluate this. Is the care plan mentioned? The care plan is not mentioned. I can't make an independent decision. Good? Make sense? Questions? Any other questions on chapters 8 or 9? Any other questions? Franca says, good morning, Miss Patty. I passed my New York State test, both written and skills, on Saturday. Congratulations to you. Welcome to healthcare. Thanks for the videos, lectures, and books. I was wearing my pink heart shirt I won last game show for motivation. Congratulations. I'm super, super proud of you. And thanks so much for tuning into the game show. All right. We just created some new graphics for the t-shirts. So I won't be debuting them this game show tomorrow, But the next one starting in June, we'll have, I think it's 4, is it 4, Jake? 5 new patterns that you'll get to choose from for the t-shirts. So that'll be a lot of fun. And I think I may put them up on the website for sale as well. We'll see. All right, 1 class left, guys. If you have not registered for the state exam, what are you waiting for? What are you waiting for? It could be money, and that's valid. It could be vacations, and that's valid. Those are valid. But if it's not one of those two, if it's just, I don't think I'm ready yet, register. You are the most prepared that you will be. You are the most prepared right now that you will be. Because once you leave on Wednesday, you'll have a day of practice that you can come in and practice, but you're not going to advance your confidence much. And what will end up happening is the further you get away from class, the more you forget, the less confident you will become. And before you know it, 2 years have gone by and you're sitting back in my classroom again because you didn't test. I enjoy seeing you. I would be happy, but I'd rather see you out in the community in your scrubs going, oh my gosh, Miss Patty, I got a job at whatever, rather than seeing you sit back here all the time. My kids won't go to Walmart with me anymore. They won't, because every time I would walk in, somebody is like, oh, Miss Patty, I took my test. I did this. You won't believe what I saw. Or, they have a story about where they're working or something. So yeah, I want to see that. I don't want to see you back here. I want you to test. Okay. I want you to test. We need you out there. We need you. Good. So make sure you register. All right, testing care plan sets are available. This might be important for you if you're planning on practicing at home. Because remember, the backs of these have the actual testing checklists. So if you get these and you're practicing at home and you pull one of these and you do those 3 skills, just have somebody with a dry erase marker, because they're laminated, checking off the steps that you do. And it's a way for you to do a mock exam at home without having to have, the classroom or anybody there with you, other than somebody just to check off the list. Game show is tomorrow. Tomorrow's questions, I think, are the easiest questions on the exam. They're communication questions. And when I explain to you how to answer a communication question, the answer will become immediately obvious on the state exam. And the rule that we use here is read the room, READ. We've all heard that term, right? Read the room. Well, READ actually means something: respect, empathy, acknowledge, and discretion. And we use that to figure out what the right answer is. You can always tell a communication question. They're super easy to pick out because it always ends with, how should the CNA respond? Or what should the CNA say? Well, that's a communication question. There are some communication questions, though, that will be communicating with cognitively impaired patients, like dementia patients. And those, the answer is usually pretty simple. Redirect. Redirect. Get them involved in an activity. Take them for a walk. Distract them. Sing a song together. Redirect. We never lock them in their room. We never punish them. We never isolate them. We never yell at them. We never make them feel like an idiot. We never say things like, don't you remember? No, they don't. That's why they have dementia. Right? We want to read the room. Make sense? So if you're reading a question and it's a dementia patient, your answer is most likely redirect. If you're reading a question that says, how should the CNA respond, and it's not a dementia patient, pick the answer that shows respect, that shows empathy, that acknowledges their feelings. So things like, that must be hard for you. Or I can't imagine how you must be feeling. acknowledge what they're feeling, not change the subject, not run away, right? People that are having a crisis need to talk about the crisis. You're the one in the room. You don't have to talk to communicate. All you have to do is listen. Just give them the option. And then discretion is going to play a part in this, and that's the whole HIPAA thing. We don't share information with anybody that doesn't need that information. Okay, so those are our rules for communication questions. You now have all the information you need to answer any communication, whether it's dementia, whether it's a regular communication question, or it has to do with HIPAA. Just read the room. Good? So I'm going to have 15 test questions on this tomorrow at 11 o'clock.
So for me to get on there, do I have
It's
to-
YouTube. YouTube. So you go to youtube.com/foryourCNA. But if you've signed up on our website and you've put your phone number in, Jake actually sends out a link right before through text message, right before the game show, about 15 minutes before. You just click the link and you're in.
Oh, I've never got a text message.
He only sends them out for the game shows.
Oh, okay.
So the very first, was it the first week? Could be the second. I think it was the second week of the program. He sent out, did you get a text for the game show on week 2? If not, check with Jake after class, and he'll be happy to take a look to see if we have your number and make sure it's right. But we send a text straight to you. So all you have to do is click the link and you're in. Super easy to join. Okay. Good. All right. So remember, read the room. If it's a communication question, read the room. And that kind of makes sense, right? Because that's all, that's what read the room is all about. When you say something that you shouldn't say, somebody's going to say, read the room. It's communication based. CPR. Now, we haven't talked much about CPR. You do not need CPR for this class. You do not need CPR for the exam. You need to know about CPR because that may be on the written test, but you don't have to prove that you are CPR certified for the test. But you will need it to work in most settings. So you want to be thinking about CPR. Now, there's something I have to explain to you about CPR, though, that really confuses a lot of students. We are familiar with that term CPR, cardiopulmonary resuscitation. We're kind of familiar with the term and the concept and things like that. But in healthcare, we don't call it CPR. We call it BLS. Now, CPR is what lay people use. Okay, so that's what, if you're not in healthcare, that's what the class you go take. Teaches you how to push on somebody's chest, how to give them a couple breaths, how to call 911, the basics. Okay, so if you're pulling somebody out of a pool from a drowning, you'll know what to do. You don't panic. The whole point of CPR is do something. Something is better than nothing. Okay, that's kind of the whole point of CPR for lay people. But when you work in healthcare, CPR becomes part of the job. And now it's not more complex, but it has a higher level of professionalism because you're getting paid to do it. Make sense? Good? Okay. So it's kind of like the difference between a shade tree mechanic that can change your oil and a mechanic shop that doesn't just change the oil, he also does a diagnostic on the car as well and looks for problems. Make sense? Okay. So the oil is still getting changed, but what is the level of competence of the person doing it? That's why healthcare providers don't take a CPR class. They take a BLS class because our expectation of professionalism is a little bit higher in healthcare. Good? Now, the other reason that we call it BLS is because in healthcare, we have more toys. We have more things we can use. So if I'm pulling somebody out of a pool that's, a drowning victim and I'm in the middle of nowhere or somebody's house, I don't have any tools to use, right? It's just me and the patient. We're doing CPR. Somebody's calling 911. We're hoping for the best. But if I am in a clinical setting or I am on an ambulance, we have tools we can use. We have a defibrillator right there. We have a mask, so I'm not blowing directly into their mouth. We have, different things that we can use, but those are the two main ones, the two main differences. So when you take a CPR class, you're going to be trained to have somebody call 911, look for a pulse, look for breathing, start chest compressions. Okay. That's what you're going to be trained to do. I used to train 9-year-olds to do CPR. Not a real high complexity skill. When you take a BLS class, you're going to learn all of that and how to use a mask and how to use an AED, where to put the pads, how to push the button. That's it. That's it. You're not reading anything. You're putting the pads in the right place. And there's a graphic on the pads that show you. And you're pushing a button to turn it on. The machine goes from there. But you kind of have to get over the anxiety over, oh, it's a new thing. I don't know what to do. I don't want to do the wrong thing. I'm going to do nothing. Remember that something is better than nothing in an emergency situation. So all we're trying to do is get you a little bit familiar with it so you don't do nothing. Make sense? So as a healthcare provider, you don't want a CPR class. You want a BLS class. Do you guys understand the difference between the two? Okay. Pulmonary. So cardio is heart. Pulmonary is lungs. Resuscitation means to get them going again. So BLS is basic life support. It's the same thing. We're doing CPR. It's part, CPR is part of, but we're going to call it something different because we got some other tools that we can use as well. Most healthcare settings, and you would want to look at the job description. We're going to go over that next class, but you want to look at the job description. Most healthcare settings don't just want BLS. They want American Heart BLS. They're pretty specific in what they require. Not all. Some healthcare facilities are like, I don't care who you get it from, just get a BLS card. But most are like, no, we want it direct from American Heart. So you want to look at the job description of whatever job you're applying for and make sure that you comply with those requirements. No, for the purposes of the exam isn't going to test you on how to do CPR. It's not going to say how many how many chest compressions to breaths. They don't ask that. What they would ask on the exam, this is a very common type of question. You walk into a patient's room and you notice that they're lying on the floor. What is your first action? A, put them back in bed. B, run and get the nurse. C, evaluate for a pulse and breathing. If not, start CPR. Or D, call 911. Yeah, we actually are going to evaluate first and then call 911 in a healthcare setting. And CNAs, by the way, here's a test tip. CNAs don't call 911. CNAs don't call 911. So let me demystify this for you. Why do you call 911? What kind of help?
That's why we need the nurse.
What kind of help? We want trained help, right? We want somebody that knows what they're doing, right? If we called 911 and a plumber showed up, right, that's help, but is that the right kind of help? No, we want trained medical help. Well, in a facility, we already have that. And they don't have to drive to get there. They're on site. So CNAs don't call 911. When you call 911, you're calling for trained medical help. You've already got that. Who should you go to? The nurse. Absolutely. So when you see that answer, call 911 in a question, think very, very carefully before you choose it. Because if you have access to a nurse trumps 911 every time. Now, the exception to that is if you are working in a home setting. There is no nurse in the bedroom, right? So if you are in a home setting, your answer is probably going to be call your supervisor unless the patient isn't breathing, and then we call 911 first. Good? So if we go in a room and the patient is down but conscious, we're calling our supervisor for direction. If we go in a room and the patient is down and unconscious, we're calling 911. Now, that's why a lot of CNAs get home health aid training to work independently at home. Because right now, you've been trained from hour one, day one, to rely on the care plan and the nurse, right? Those two things. In a home care setting, you probably don't have either. So everything that you've learned, right, on how to handle things is kind of like out the window in home care, right? We're following all of that. Yes, absolutely. We're checking the water. We're going to have them check the water. Patient should always be in the middle of the room, right? We know when to wear gloves. All of those things still count. Absolutely. But following a care plan, well, if you're working for an independent family, there is no care plan. If you went on to Craigslist and said, hey, I'm a CNA. In fact, there was just one this weekend. I'm a CNA in Brooksville and I'm looking for a private care opportunity, right? Is that person going to have a care plan? No. Be careful. There's liability there. Be careful. But if she goes to work for a family and she and the family agree what's going to be done, there's no nurse. So who does she report these issues to? Yeah, but she better figure out how to handle an emergency pretty quick, because in emergencies, we don't have time to figure it out. We better know. So that's why the home health aid training becomes important. If you're going to work independently at home, you need to know some things that are specific to the home. One of the other things is what chemicals you really should not be mixing. That's a big one, especially if your patient has respiratory issues. We don't want to use aerosols. No Lysol in the air if somebody has a respiratory issue. It's probably not something that you thought about, right? So that's the difference between, on a test question, between get the nurse or notify the nurse and call 911. CNAs in a clinical setting, we don't call 911. We call the nurse. And then the nurse decides whether it's serious enough to call 911. Okay? So there's another written test question secret. If the answer is call 911, probably not the right answer. Call a nurse. All right, so we have a QR code here. This does give you a discount to Julie's class. It's right here in this classroom. You have this on your first day handout, what we call the blue sheet. And it's also, I think, it's on the bottom of your syllabus. No, I don't think it is on your syllabus. It's on the first day handout. But you can take a picture of this as well. I'll have this up next class as well. Oh, you need me to go back? I'm sorry. Go ahead. Go ahead. All right. So one thing that I want you to do before the next class, there's something called the Workplace Personality Quiz. It'll take you about 5 minutes to take. And I made this because I had so many students asking me, what's the best place to work? I got that question every single class. So, Miss Patty, what's the best place to work? And the answer is, it depends. Depends on you and your personality. It's not as easy as saying, yeah, everybody should go to the hospital, or everybody should go to a nursing home, or everybody belongs in an ALF when you first start. That is not true. And the reason that we have to consider this is because if you pick the wrong workplace for your first job, you're likely to leave healthcare completely thinking it's not for you. It wasn't healthcare that wasn't for you. It was the place you chose to do healthcare that wasn't for you. So we got to get this right, especially the first time out of the gate, because otherwise all of the effort and the time and the money that you put into this could be wasted. So I want to help you with that. When you're thinking about where do I want to work, we don't want to base that decision on Grey's Anatomy, on a TV show, okay? Because I guarantee you, Dr. McDreamy is not in any of our local hospitals I've checked, okay? So how then do we figure out where we want to work? And the answer is we need to figure out a little bit about you, not your skill level, because you have none. Everybody here has no skill level, okay? So that's not going to really play into this. What we want to look at is what kind of shift do you need? If you're going to school, I know I have somebody in here is in school. Who's anybody? No? If we have somebody in school that's going for their LPN or their RN or planning to go, you need a workplace setting that's going to work with your hours. That's going to be an important criteria. If you have a daycare that closes at 5 p.m. on the dot and you don't have anybody to pick up your kids, that's going to play into your decision because hospitals do 12-hour shifts, 7 to 7. Okay, who's picking up your kids? If you're still at work, they're not going to let you off at 4:30 because you have a daycare problem. You are there until, so that's got to play into your decision, right? So your schedule is going to have a big impact on the workplace that you belong in. You also need to kind of figure out, do I work better as a team or am I better kind of on my own? If you work well as a team, then a hospital is probably right up your alley. But if you're more of a, yeah, let me have my assignment, then just let me go do what I need to do without a lot of drama, then the hospital, not your place to be. Because everybody is constantly all up in your business. Okay? This is something you need to take into consideration that you probably haven't thought of. What kind of healthcare do you want to practice? Are you the type of person that likes a lot of technical stuff? Okay, you want the machines. You want the lines. You want the, the high acuity, a lot of stuff going on with your patients type of thing. Then hospitals or rehabs might be a good idea for you. If those things scare the crap out of you, and all you want to do is take care of the patient and make them comfortable and clean and felt cared for, then a long-term care setting, right up your alley. Are you the type of person that wants to really get to know your patients, develop a relationship? And Mr. Jones, you've had Mr. Jones now for 2 years. You're able to see, hey, there's something wrong with him today. He's a little more off today. Can't really put your finger on it, but you just know because you know him, right? Or are you the type of person that just wants to go in, see the patient, get it done, and get out and not really form any personal relationships You want short care. Okay, that's hospital. Those people are only in there maybe a day, maybe two. You're not getting to know them. You do not know who their kids are, and frankly, you couldn't care. Okay, where Mr. Jones, you know his kids, you know his grandkids. You can recognize them on sight, say hi to them in Walmart. Two different kinds of nursing. Which one fits you? Are you looking for a lot of benefits? If you got some health problems, you need insurance, that's going to play a part in your decision. Have you guys thought about any of this?
Yeah.
Okay. What I do in this is I have you answer 19 questions. They have nothing to do with your skill level. They have to do with what kind of nursing, what kind of patient, what kind of setting. And I accumulate all of those answers. And after you're done, takes 5 minutes, I tell you what the ideal workplace for you is. Is it pediatrics? Is it mental health? Is it an ALF? Is it a hospital? Is it a rehab? Is it a walk-in clinic? There's 9 different settings that this is going to spit out, and it's scary accurate. I tested this on thousands of already working healthcare providers, nurses, CNAs, techs, and it is scary accurate. So if you want an insight into you and the best place for you based on psychology, not guessing, not TV, this will help you. Now, this is on my main website. Just go to foryourcna.com. Up in the menu under training, you'll see workplace quiz or something like that. Just click it. Okay. If you take this before class on Wednesday will make a whole lot more sense to you. I believe this is also in our after class wrap-up email that we send you. Okay. Jake, can you just verify that, please? That the link for the workplace quiz is in our after class wrap-up email for class 8. Or I'm a 7. Sorry. All right, so quick review. How do we know what to do with each patient? We follow and it's the care plan, the whole care plan, and nothing but the care plan. While we're doing that, we should be making some observations. And who do we report those observations to? The nurse, absolutely. Every skill, now that we know what to do, starts with the opening. Every opening starts with a knock. We're going to greet the resident, address them by name, introduce ourselves by name and title, tell them why we're there, and get permission. Then we're going to close the curtain, wash our hands, and get our supplies. Cardinal rule, do not touch that patient until your hands are clean. One of the supplies we might need are gloves. We have to figure this out based on the patient, not the skill, the patient. You can do range of motion without gloves, but not if the patient has body fluids that you're going to be contacting or has an incision near where you're going to be holding. It's based on the patient, not the skill. Very good. Thank you, Jake. If you do wear gloves, the first thing those gloves should touch is the patient, not the supplies, not the environment. Keep those gloves clean for your patient. Once you have touched the patient, be careful what you're touching the environment. Don't unnecessarily spread body fluids throughout. And then we remove our gloves correctly by pinching up at the cuff, taking it off, going underneath, and taking that one off. A barrier is used anytime we use supplies. We have to have clean hands to get our clean supplies, and those clean supplies need a clean place. So we wash our hands, we go get a barrier, we put it on the table, and then we go over and get our supplies. Don't hold the supplies up next to your uniform. We may need a privacy blanket. And remember, these are not just for privacy, they're also for warmth. Your perception of temperature, different from your patient's. My perception of temperature in this room right now, this minute, is different than yours. I'm standing up. I'm moving. I'm talking. I'm creating a whole lot of body heat around me just by talking. You guys are over there wrapped up in sweaters. I'm about to tell Jake, hey, turn that air down because I'm starting to sweat. You guys are all like, no. I'm already freezing. Don't touch the thermostat, Jake. Our temperature perception is completely different. Don't ever forget that in a clinical setting. You may be comfortable, but that doesn't mean your patient is. We have to understand in healthcare, and I've talked about this a lot, not this directly, but I've given you a lot of insight into this in different principles as we've gone through. We are separate from our patients. Now, in our minds, we try to attribute everything that we are to our patients. The way we eat, we're going to feed them that way. The way we would like the water, we're going to do that to them. The way we're comfortable in a room, we're going to do that to them. I don't care if I'm uncovered in front of a stranger. We project onto them. You have to be really careful not to do that. You have to remember that you are completely separate from your patient. And I've spent a lot of time on this in the program. When you're out there working, don't ever forget that. Do not ever attribute you, your characteristics, your likes, your dislikes to this patient. And I'm going to tell you one of the biggest areas that this affects: communication. When you are talking with a patient and they say something like, I'm afraid I'm dying, we want to run from that conversation. We don't like that conversation. We are immediately uncomfortable with that conversation. We're going to change the subject. Well, lunch is like in 10 minutes. Okay. Does that help that patient at all, knowing lunch is in 10 minutes? If they brought it up, what does that mean? It's bothering them. They need to talk about it, right? Well, we want to run for the hills. We don't want any part of that conversation because we're uncomfortable, right? We are projecting our discomfort onto the patient, but it gets worse. It gets worse. Because a lot of times what we will try to do is empathize with the patient by bringing in our own personal experiences. Oh, yeah, my mom had what you've got. She got treated and she's better now. I mean, we just went to Disney last week and she was walking around just fine. So no, you're not dying. You're fine. Do you think this patient has anything to do with your mother?
No.
Anything at all? They're humans on the same planet. That's the only thing they have in common. Do not bring your personal experiences into this. They have absolutely no bearing on your patient whatsoever. This is not a connection exercise. You are not trying to find common ground. What you are trying to do is empathize. Let them talk. Acknowledge what they feel. I'm so sorry to hear that. That must be very difficult for you. Can you tell me why you're feeling that way? Do you want to talk about it? I'm here to listen if you want to get it off your chest. If you have questions, I'd be happy to go get the nurse. Those are all absolutely valid responses. Not, oh, you're going to be fine. That is not a valid response. You cannot make that claim. Do not make that claim. Because when the doctor comes in the next time and says, hey, we got your lab results back, it's not looking so good. You know what that patient is going to do? They're going to latch onto what you said. Yeah, but that girl said it was going to be fine. That girl said, I'm going to be okay. This is bargaining, and it's part of the grief reaction. Very normal. Don't walk into it. Okay? So your answers are, would you like to talk? That must be hard. I'm so sorry to hear that. Good. Makes sense? Never, ever, ever assume that you and the patient are the same with anything. Anything. This also, very uncomfortable conversation, has to do with religion. The patient may have a totally different religion than you, or the patient may have no religion at all. Your particular belief system has nothing to do with this patient. And you may believe that your particular belief system is that they need to be saved. They're approaching death. They need redemption or whatever. That is not your role. If the patient asks for clergy to have those conversations, that's their role. It is not your job to evangelize your religion in a clinical workplace. Be very, very careful with that. Your belief systems are absolutely valid, and I will die on that hill. You have the right to your beliefs, and I will stand up for your beliefs every day of the week. But I will not stand up for you imposing those beliefs on another, because I'm going to stand for their right, for their beliefs, just as vehemently as I'm standing up for yours. Good? Do not equate your life experience with the patient's. You are two separate beings.
There are people that ask, that happened to me.
Mm-hmm.
Am I gonna die?
Mm-hmm.
I don't want to die. It was, a lady that died.
Absolutely. That's a very, very, very common
I don't want to die.
situation.
And I said, well, we're all gonna die.
That is not helpful to that patient. Not
I
at
didn't know
all.
what to say. It was like,
That must be very frightening for you.
what should I say?
That must be very frightening for you. You're not getting it.
You tell her
That must be very frightening for you.
Next time. I work with people that die every day. so-
Sure, absolutely. And we all do in healthcare. But what you're trying to do is give them an opening to talk. You saying we're all going to die, did that give her an opening to talk? It shut her down. Yeah, and you shut that conversation off because you were uncomfortable. You shut that conversation off. That did not help the patient. If they're saying, I don't want to die, they're afraid. They're scared. They want to talk about it. And they're reaching out to the only person in front of them because their family isn't visiting. Now you say, oh yeah, we're all going to die. That tells them that you don't want to hear it either. So now they're in their room alone with those thoughts and nobody to bounce them off of. How tragic is that? So your response is, that must be very frightening for you. Now that gives them an opening. That allows them to talk. But if I say, yeah, everybody's going to die, that shuts the conversation down. And it actually just worked on you. That phrase just worked on you. It works. A very simple, would you like to talk about that? It sounds like you're upset. Would you like to talk? Let's go for a walk. That's fine. That's fine. If she can't walk, that's fine. Yeah.
She was already morphine and she was like not eating yet.
And do you think her fear was valid at that moment?
Oh, yeah. Well, I don't know.
She's dying.
Oh, okay, yes.
You just told me she is
She
dying.
was dying.
She died the next day. So was her fear valid? I think I'm going to die. She died the next day. Was her fear valid?
Yeah.
And nobody did anything about it.
Oh no, well, her family was. And I love her.
I'm not trying to shame you. That's not where this is. What I'm trying to do is show you that what we do matters. How we react matters. This woman is dying. You just told me she died the next day.
Yeah.
She said, I'm afraid I'm going to die. And she was right. She knew it. She was right. And they always know it, by the way. They know.
Oh, you saying they know when they're gonna
They
die?
know. Yeah, they know.
Start talking.
So she wants to talk. Oh, I'm pulling up a chair. This is somebody in distress. Yeah.
She started talking about her. She was one of the first mermaids in here.
How amazing.
And we start talking about that. And she, I talk about that. And she started talking about her reminds and stuff like that. After that, like,
Right. She wanted an opening.
yeah, and we talk about that for a while until her daughter came and we started talking about
Very good. That's the way to handle it.
I didn't know what to say when she said that.
Yeah. So
But
instead,
before.
instead of everybody's going to die, which shuts down, a better is that must be frightening for you. Or would you like to talk about it? Or it sounds like you're concerned. Something that acknowledges what they're experiencing. But you just landed on something I want to talk about really quickly. Everyone has a story. Everyone in this room has a story. You have a story. What is the story of your life? Give me a quick rundown of your life. Just quick.
My father passed away. My brother passed away. My mother-in-law just passed away. I mean, everybody's just leaving.
So it sounds like you've had a lot of loss in your life. How are you dealing with that?
I just keep going.
Keep going. Yeah, distraction sometimes does help. It does work. Where did you live before? Have you always been in this county?
No, I'm actually originally from South America.
Oh, how fascinating. So you have a big story. You immigrated. It's a whole different culture. Right? So you have a story. Now, did you guys see what I just did there? Did anybody catch what I just did? Okay. Important though, because you are ideal for this exercise. Important though, she has a story. How tragic would it be to get to the end of your life and have a story? And nobody wants to hear your story. Nobody cares. How tragic would that be? Every person has a story. Part of our job is to listen to their stories because your story makes you. Now, it was very interesting, and if I had more time, we would delve into this. It's very interesting that she did not start with immigration. It's very interesting that she did not start with her marriage and children. And what did she start with? Loss. Loss. Loss is a recurring theme in your life. Loss is something that is top of your mind at the moment. That is something that obviously you are looking to explore. So all I need to do is give you an opening. Does that help you guys? Every person has a story. Now, on camera, I don't want to get into your loss, right? So I redirected you. Have you always lived here? Right? So your story, one of the very first mermaids, if I'd asked, have you always lived here? She would immediately go into that. Right? So now I've got an entire hour's worth of conversation about something that's actually factually interesting. All you got to do is give them an opening. Every person has a story. I have met people or a man that was knighted by the Queen of England. Tell me that wasn't a story. I met somebody who was an engineer for the Apollo mission when we sent people to the moon. That's a story. I had a patient who was a major baseball player. That was a story. Everybody has one. I met a woman who had like 21 children. That's a story. Everybody has one. Even people that don't think that they have a story. I'll tell you one of the most interesting conversations I've ever had, ever, was with somebody who did not think that they were interesting at all. I was taking care of a woman up in Citrus County. She was in an assisted living facility, not a nursing home, assisted living, had her own little apartment, and she was in her late 90s. And this is probably about 25 years ago, maybe even a little longer than that. And she had horrible wounds on her legs that were going to take me probably 30, 45 minutes to take care of because I'd take the old dressings off, clean, and re-bandage the wounds. And it's a very long, complicated process. So I pull up a chair and I ask the one question that I pull out when I don't have any connection to anybody. What's the most exciting place you've ever been? And she says, oh, honey, I've never been anywhere. And I said, oh, you've never been anywhere. We're in Citrus County. You had to have gone somewhere. I mean, come on. It's Citrus. You're in Lecanto, you know. And she says, no, I've never left the county. Hold up. Wait a minute. You're in your 90s. You've never left, not once. You never went to Ocala? She says, no, I've never been out of the county. And I said, that's crazy. Where did you honeymoon? She says, oh, my aunt had a cabin out in Floral City. It was delightful. Right? So I made her smile. Did it cost me anything? But I'm thinking, okay, hold up. This woman is in her 90s, late 90s. She's never left the county. And then she says, oh, well, that's not technically true. I was born in Brooksville, but I don't remember that. Well, obviously, right? Because that's before Citrus County had a hospital. That's how long ago this was. So I am now invested in this conversation because this is living history sitting in front of me. The same county that I grew up in, she has never left in almost 100 years. Do you know how many changes have happened in Citrus County in 100 years? She remembers when the roads were paved. She remembers when the first McDonald's showed up. She remembers the first car dealership. But the story that she got the most enjoyment out of was there were two families in Inverness that were rivals. And the boy from one family was supposed to marry the girl from the other family. And she ran off with the boy next door. And what a scandal that was. So it wasn't the advances in the county that she was most enamored with. It was the people. And that gives us lots and lots of opportunities for conversations. Because at the end of the day, that's what it's really all about, are the people. The connections we make with others. And if we aren't making connections with others, we're losing an opportunity for them, but also for us. So don't shy away from those conversations. Open them.
We don't like, but dying.
Yeah, even the ones, especially the ones that we don't like, because those are the ones that they need to talk about. Okay, good? Makes sense? All right, so now that I've spent all of our review time on that, I'm going to just skip all the review. Go back to class 4 if you want to review, okay? All right. Let's get into today's, there we are. All right, let's get into today's lesson. We have assist with bedpan. If we look down the side here, we can see all of the principles that are involved in this particular skill. They're all spelled out for us here. We know skill rules. We know the opening. We know glove rules. We know the barrier rules. We know keep the patient in the middle of the bed, scoot and roll. We know basin cleaning, and we know the closing. There's nothing new to learn here, except for the skill-specific steps. And even the steps themselves, there's not much to learn. What we really need to focus on for this particular skill is the equipment. Okay? So if you look on page 148, we have our care plan at the top. We have some step-by-step instructions here, and we have our supplies at the bottom of the screen. Now, when you're practicing at home, if you have the test and care plan set, okay, let me pull up Bedpan here real quick. Okay, so this is assist a resident with a bedpan. So if I turn the page over, right here are the steps. The steps are numbered. Okay, the steps are numbered. So if you go through, just take a look at this. Okay, pick a number. Just pick a number 1 to 33. Pick a number. What is it? 24. Okay, so step number, pick another number. 9. Okay, so step number 9. Here's our step, right? So this tells you what to do, the student. This is telling you, do this. So throughout skill, ensure patient remains a safe distance from edge of bed at all times. Now, behind that, you see a number, 14, right? So when you're practicing at home and you have this open and you're following these steps, if you have somebody at home who has this, you can read that to them. Throughout skill, ensure patient remains a safe distance from edge of bed at all times, 14. They look at this, they find 14, and this is what 14 says. Keep resident positioned a safe distance from the edge of bed at all times. What does it say? Ensure patient remains a safe. It's the same thing. So when you are following this and you have somebody with this, you can tell them the number and they can check it off. These numbers cross-reference to this checklist. So if you use the two of them together when you're practicing, you will get 100% on the state exam.
Now, do we have those in the book that you have in your hand?
No, these, you have the way to get this is step by step here, but the actual checklists are always up here for you to use when you're practicing, or you can purchase them. Okay? But it's a way for you to grade yourself at home before you ever take the test. Now, this is really important for those of you who have no confidence, who are afraid to register for the test because you just don't want to fail. If you have no confidence, you need those checklists to be able to perform, check off, cross-reference. I've done the work for you guys. All you have to do is follow these steps, and you will get those check marks, and I tell you where the check marks are that you're getting. Good? The three work together. These in your book, the checklist on that, and you performing the skill. So let's take a look at this care plan. It says the resident has requested a bedpan. The resident is not wearing undergarments and is able to wipe self. The resident is able to move as directed. So I want you to underline or highlight that. It says the resident is not wearing undergarments. Now, the reason that that is important, it never happens like that in a real life clinical setting, but the reason that is important for the exam is if you go back a page or 2 pages, yeah, see down here, it tells us that a live testing student is going to be our patient for this.
Oh my God.
You might find yourself on a bedpan. Hold on, don't panic. I know everybody's like, wait a minute, I didn't sign up for this. Okay, what does our garment say, or what does our care plan say here? They're not wearing undergarments and they're able to wipe self. So for the test, you stay fully clothed. Please do not take your clothes off. They will give you a hospital gown to put on over your clothing. And if anybody tries to take your clothes off, the evaluators are going to point to the care plan. The care plan says that they're not wearing those undergarments you're trying to pull off.
Nobody wants to see how do you wipe yourself.
Right. And if somebody tries to wipe you or get anywhere near your personal area, the evaluators will stop them and say that is not required according to this care plan. Well, there's a few more steps than that, but yes, essentially, this is a simulation skill, which means that there really isn't going to be anything in the bedpan. We're going to put it under the patient. We're going to take it out. We're going to clean it, but there's not actually going to be contents in the bed. We're going to pretend there's contents. No, I know. Yeah, we're not trying to win Academy Awards for the test, sadly. I know I could improvise like crazy. All right, so we know all of these steps. There's nothing here to learn. We've got all of these down. So let's look at the skill-specific steps that we need to know for this skill. Before we get to how to do the skill, I have to explain to you just a little bit about bedpan because CNAs have this completely backwards in their head. For some reason, CNAs think bedpan is the first choice for a patient for toileting. I don't know why, but CNAs tend to default to bedpans. That's actually completely backwards. Bedpans are the last resort. Remember that CNAs don't get to decide how a patient bathrooms. Who does that? The nurse, right? Right. It's in the care plan. So the nurse gets the orders from the doctor, evaluates the abilities of the patient, and develops the care plan. So the nurse is looking, is the patient continent? That's step one. Can they hold their stuff? Do they toilet? Right? If the answer is no, they're incontinent. We have a whole process for that. Pericare every 2 hours. We already know how to do that. If they are continent, now we're going to go down this train. Okay, so they're continent. First question, can they do it all themselves? Do I have to be involved in this? Because ideally, I'm not involved. Like you guys all get up and go to the bathroom by yourself. I am not involved in that, thank God. I don't want to be involved in that. So ideally, you go take care of it yourself. Margaret says, thanks for assisting past New Jersey written exams. I appreciate your videos. Very helpful and informative. Well, congratulations to you. Great job. Welcome to healthcare. All right, so ideally, this is what I'm looking at. Patient goes by themselves. A lot of times, this is going to be a patient in a hospital or a rehab. We're not involved. But in healthcare, they're there for a reason. So a lot of times, they're not going to be able to go just by themselves. They may need a little bit of help. That would be bathroom with assist. Now, if they go all by themselves, nobody else is involved, just them and the toilet, that's called bathroom privileges. We're not involved. If they need some help, it would be bathroom with assist. They're still going to the bathroom. We're just going to help them out with whatever they need. Might be walking there, might be sitting down, might be standing up, might be wiping, but whatever they need, we're going to help them with that task. Good? Now, if the bathroom is not an option, too far, they're too weak, they're too shaky, they're too dizzy, they can't bear weight, whatever the case may be, we have a portable toilet that we can bring to the bedside called a bedside commode. Kind of looks like a toilet, has a little bucket attached to it, but it feels like a toileting experience. CNAs can either clean it out once the patient uses it, if they're using it independently, or CNAs may need to help them transfer on, clean up, or transfer off. So bedside commode or bedside commode with assist. So first choice is always going to the bathroom by yourself. Second choice is going to the bathroom with assistance. Third choice is bathroom to you. Fourth choice is bathroom to you with assist. Now, once I get to here, if the answer is no to all of those as a nurse, I've only got 2 options left, and I don't like either of them. So the first thing I'm going to consider is is a catheter necessary? Now, catheters are not used for convenience. They're not used for convenience. If the pee can come out on its own and isn't going to interfere with anything on the patient, we're going to let the pee come out on its own. If the pee cannot come out on its own, or it would interfere with something, then a catheter is indicated. So if I've got a patient with a huge bed sore on their back, I don't want them laying in urine. Remember, urine is acidic. It's going to eat that wound. Not a good idea. That patient would probably need a catheter if they cannot get to a bedside commode or a bathroom. Okay. This is not automatic. This is highly selective, and we're going to find out why in a few minutes. So if a catheter is not indicated, I'm only left with bedpan. This is the last choice on the list, not the first. Now, why is this last? As a patient, bedpans are hard to use. They're uncomfortable. They don't hold a whole lot. They're not private. But the real problem is a psychological restriction. You have been trained from the time you were this tall, don't pee in the bed. Don't pee in the bed. Do not pee in the bed. And certainly don't poop in the bed. Just because I put a plastic pan under your butt does not mean your brain is going to be able to overcome that conditioning. Do you guys remember what we learned about memories that are formed early in life, right? They're the strongest. So just because we put a bedpan under somebody does not mean they're going to be able to go. Because their brain's going to go, hold up, do you know where we are? Do you see the bed? Not going to happen. And this may take a lot of patience on your part. You put a bedpan under the patient, they can't go. You take it out, 20 minutes later, they go, yeah, I really got to pee. We put the bedpan under them, they try again. They may not be able to go. We take it out. We give them another little bit, and then we put the bedpan under them again, and now they're able to go. This may take a little bit of patience on your part. Good? Good? All right. The other problem with the bedpan is functional. Let me show you what I mean. Toileting items, all toileting items are always in the bottom drawer of the bedside cabinet, right? We don't want toileting things over toothbrushes. Toileting is in the bottom. So let's take a look at our bedpan here. Only touch bedpans with gloves. Don't do what I'm doing. All right, so I have a bedpan here. I have a seat on a bedpan. This is where the butt goes. Looks like a toilet seat. It's where the butt goes. I have a lip of a bedpan that's a little bit higher that kind of goes up, curves around the body to direct the urine in to the bedpan. So when I put the bedpan under the patient, it goes in like this. Good? All right, but the part that they're actually sitting on is this part here. If you look down here, do you see how much space that is? Not much space. That much space. Pee comes out under pressure. Hits a flat plastic surface this far away. You're going to get splashback. There's no way around it. So when a patient pees into a bedpan, we get splashback. Their whole undercarriage is going to get wet. Now, that splashback effect, if you experience that on a toilet, you clench. You stop peeing. So what do you think is going to happen here? Yeah, when they get splashback, they're going to clench. So we've got this psychological restriction going on, and now we've got a physical response causing us to clench. Do you see why bedpans might prevent our patient from being able to go very well? Good. Remember, liquid under pressure hitting a flat plastic surface always causes splashback. Now, defecation poses its own problems because now we've got odors to deal with. And the only thing separating this person from another stranger 3 feet away, their roommate, is a thin curtain. Do you think that curtain does anything for odors? No. So this patient is acutely aware of this, and that's going to really restrict their ability to freely defecate. So if we have a patient who has to use a bedpan, the best option, the very best option, if the roommate can walk, this is a great time to take the roommate for a walk. Get them out of the room. Provide some privacy for this person because the curtain may be shielding them from view, but not from sound and not from odors. And both of those things your patient will be acutely aware of. Make sense? Good. So things you didn't think about with a bedpan. All right, this is why it is a last resort. I'm going to give you some tips in just a moment that will help with all of this, but understand that bedpans are a last resort. So for this skill, if we look at the care plan, it says the resident is able to move as directed. Thank God, because that makes this skill so much easier. When a patient's laying in the bed like this, if you have them bend their knees, put their feet on the bed, they can lift their hips up. It's called a bridge. And that just lets us slide the bedpan under them. Super easy. And the nice thing about this is our care plan says they can. So just have them lift their hips. Easy peasy. But what happens if your patient can't lift? We know they can't for the test. Cool. But in a clinical setting, not all your patients can be able to lift their hips. What happens then? Well, then we roll them on their side, put the bedpan up against their butt, kind of standing up, and then roll them back on that bedpan. Let them go. And then when they're done, we're going to hold the bedpan flat as they roll off of it and take it out. Make sure you hold that bedpan flat because otherwise, what happens? Yeah, they wear it. Absolutely. So we're going to ask them to lift their hips for the test. We're going to place the chucks under them. We already know how to do this. Clean rolls toward me, dirty rolls away. We've done this. We did this with an occupied bed. We did this with peri-care. This is easy. This is nothing new to learn there. Once we get a chucks under them, and the reason why we have to put a chucks under them is because we don't want urine to splash on the sheets. We're going to put the bedpan under them. Remember, if it looks like a toilet seat, it's where the butt goes. And once we get the bedpan under them, the most important step for this skill, the most important step for this skill is to put the head of the bed up. And let me show you why. If we have a patient, this is my patient laying on the bed, and I put a bedpan underneath the patient, what does it do to their hips? Raises them up. How many of you ladies can pee uphill? If you are successful, and you probably won't be, but if you are successful, that urine is going to go right up your back and into your hair, and that's pretty high on everybody's gross meter. When you put a bedpan under somebody's hips, it raises their hips. Now, if you think urination is hard, imagine having a bowel movement in that position. They're not going to be successful. So the most important step of bedpan is raising the head of the bed and getting them into a normal elimination position before we leave them to do their business. They need privacy to do their business. Don't stand there and stare at them. Eye contact when somebody is pooping, very uncomfortable. Get out of the room. Wash your hands. Go do something. Now, for the test, it's a problem because we have nowhere to go. Okay, I was just going to ask. Right? This is our only room. This is our only bed. This is our only patient. We're stuck here. So what we're going to do is step on the other side of the curtain and just wait during the test. You don't have to go wash your hands. You're not leaving the patient environment. Just step and wait. Okay? Good? Good. But in a clinical setting, don't wait. Do not stay in that room. They need some privacy, please. please. All right, good, good. All right, so now we have the head of the bed, or I'm sorry, we're going to put the head of the bed up. The problem with this is that we have just put a chucks and a bedpan under their butt. We have butt juice gloves. Do you want, yeah, you can, but we don't want to keep those gloves on. They have butt juice. So we're going to take those gloves off before we put the head of the, you don't want to touch that controller with butt juice gloves, do you? So take the gloves off before you put the head of the bed up. Now for this skill, you can use privacy blanket or not, doesn't matter. This is one of the areas that I differ from the state exam, okay? The state exam does not require a privacy blanket. In fact, the checkpoint that we're going to be graded on is leave the patient covered with a sheet throughout the skill. I don't like that because the sheet is likely to get wet. I would rather have a privacy blanket there, keeping the bedding clean. But the state's checkpoints say leave the resident covered with a sheet during the skill. In a clinical setting, use a privacy blanket, please. So we're going to put the head of the bed up. We're going to take our, we're going to put the bedpan in place, take our gloves off, put the head of the bed up, and we're going to give them their call light and toilet paper because we're leaving the room.
So we don't wash our hands after we put the gloves on?
No. Same patient, patient cooties. They're familiar with their cooties. It's okay. If we are leaving the room after this, we would wash our hands. But for the test, there's nowhere to go. We're not leaving anything, so we don't have to do that step. Okay?
I'm sorry. So they do whatever they need to do. I don't know if I got it.
Go ahead.
You gave them the toilet paper. They do what they have to do.
We haven't gotten that far yet.
Okay. Yeah. Sorry.
Okay. So all we've done right now is we did our opening. We got our supplies. We put our gloves on. We put a chucks under them. Clean rolls toward me, dirty rolls away. We put the bedpan on the chucks. We took our gloves off and we put the head of the bed up. Now we're giving them their call light and their toilet paper. We're going to step on the other side of the curtain for the test and wait. They're not going to make any sounds. They're just going to say, I'm done. And they're not going to wait long. I mean, it's like immediately, I'm done. Good? Good? Okay. So now that the patient is done, we're going to come back to the patient environment and lower the head of the bed because you can't take a bedpan out from under a butt if they're sitting on it. We need the head of the bed back down. Then we're going to put our gloves on. So this requires 2 sets of gloves. We're going to take the bedpan and the chucks together out from under the patient. So remember, we have a chucks and we have a bedpan. We're going to take all of it at the same time out because you cannot carry an open container of urine through a room. If I trip on my shoelaces, I'm going to go face first in this guy's stuff. Plus, it's a privacy issue. Nobody needs to see what's in that bedpan. So we have to cover the bedpan, and that's what that chucks is going to do. We took the chucks and the bedpan out together. We're going to flop the corner of that chucks over the bedpan, and we're going to take it to the bathroom. Now, remember, for the test, there's not actually going to be anything in the bedpan. It's empty. But we're going to take it to the bathroom, and we're going to throw away the chucks. We're going to empty the pretend urine. There's nothing in the bedpan, but empty the pretend urine in the toilet. We're going to rinse the bedpan, and we're going to dump the rinse water in the toilet. Then we're going to dry it and store it using paper towels the way we dry and store everything. Remember, one process works on all basins. Good? Good? Okay. Now, once we've done that, we're going to take off our gloves and we're going to do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? A little late for the magazine, right? They should have had it during. But would you like a magazine or something before I go? Here's your call light. Open the curtain. Go wash my hands. read my care plan, say my skill is done. Good? Let's talk about some things that aren't on the test that may help you, though, in a clinical setting. If you're working in an acute care clinical setting, think hospitals or rehabs, some nursing homes, you may see a toilet that looks like this, different than our toilets at home. Our toilets have the tank, everything is kind of hidden. In a clinical setting, most of the time, the toilets are way more industrial. We see this pipe, and then you have the bowl. Well, in most settings, this pipe has this little thing attached to it that actually looks like a little mini shower head. And if you pivot that forward, so it's horizontal over the bowl, it will spray into the bowl. This is a bedpan cleaner. It allows us to clean that bedpan right over the toilet and dump the contents in the toilet. So we're not taking a toileting item to the sink. I like that. It's cool, but there's a problem. Do you remember about 3 minutes ago, I said that liquid under pressure hitting a flat plastic surface causes splashback? You guys remember that? Yeah, splashback, and you are in the splash zone. So if we're using a bedpan cleaner to clean a bedpan over a toilet, the particles that splashback creates is probably going to get on your uniform and could even get into your face. That's not good. Not good for anybody. So if we're going to use this, we want to put an isolation gown, a disposable gown on over our clothing to protect our uniform. And we want a mask and shield over our face to keep any particles from coming into any of our doorways.
Would this just be in a hospital setting? Or?
Hospitals, rehabs, and some nursing homes will have this.
Okay. And if they have it, we must use them or we can use the sink.
Your facility, policy, and procedure will define that for you.
Because if we have to use all that stuff, I would rather use that.
Well, if you're working on a sink, you still have water under pressure hitting a flat plastic surface. I said it very deliberately. Liquid under pressure hitting a flat plastic surface causes splashback. So that defines the sink. It defines the bedpan cleaner. It defines urine coming out of the patient. Okay. Now you don't have as much of it in the sink because we get to control the water flow. This we're not controlling the flow. It is like full force, whoosh. So you're going to have more splashback here. Good. So yes, you really should dress for the job. Questions? Questions? All right. There's two other things that we can do to make this a little bit easier on our patient, but we have to ask the nurse for both. If we have liquid under pressure hitting a flat plastic surface and that causes splashback, there's some things that we can do to help minimize that effect, but we also have another problem. We have the bedpan that is full of urine at the end of the skill. So it's going to slosh when we put the head of the bed back down, which means urine can spill out. So controlling that urine becomes a pretty big, important step. If the nurse says we can, so if we're not measuring the urine for intake and output, if we're not looking at the urine for some reason, color, consistency, that type of thing, we can take toilet paper and make big rolls of toilet paper, big loops of toilet paper, 5 or 6 big loops of toilet paper, and lay it down inside the bedpan before we put it under the patient. It absorbs the urine, prevents sloshing, but it also prevents splashback, which makes it easier for the patient to clean themselves. And we're not going to use that on the test, but remember that tip for a clinical setting. Now, there's one more problem with bedpans. and that's their plastic, okay? Have you ever, if you have a car that has like leather seats or plastic seats that look like leather seats, in the summer, if you're wearing shorts and you sit on those seats for any amount of time, what happens? You stick. Yeah, you have to peel yourself off of the seat, and that can hurt, right? Well, when we put a bedpan under somebody, their body heat is going to heat that bedpan up. They're probably going to be on it for a few minutes. So when we try to take that bedpan out, it's going to stick. Does that make sense? So if we put powder on the seat of the bedpan before we slide it under the patient, it'll help prevent that sticking. Now, we can't use powder if they have a wound or an incision of any sort. We can't use powder if they have a respiratory condition. So we need to ask the nurse, hey, can I put toilet paper in and powder on? And if the nurse says yes, yay, your job just got 1,000,000 times easier. Life is great. If they say no, well, we're going to make the best of what we have. Make sense? Good. So there are 2 tips that you can use in a clinical setting. Now, some people, some CNAs, line the bedpan with a plastic bag, you know, like a grocery plastic bag. That, I don't know why they do that. That doesn't help anything because it's still a plastic surface. You're not going to take this bag, you know, tie it up and put it in the trash, right? So that is not going to fulfill the terms. The only thing that it may do is help remove the bedpan a little bit easier, but it's still plastic. It's still going to stick to the patient. So I'm not sure why CNAs have kind of invented this for themselves. It doesn't really accomplish what they think it's going to accomplish. Good? Good? All right, when we're all done, we've got everything cleaned, we've got it all put away, our gloves are off, all of that. Your patient wiped themselves. How do I know they wiped themselves? The care plan told me they did. So we know where their hands have been. They wiped themselves. They do not have access to a sink. So what do you think we need to give them? Yeah, hand wipe, absolutely. Now, I know where their hands have been. When I hand them that hand wipe, I don't want to pick it up with my hands. I know where their hands have been. So I'm either going to grab that trash can and hold it for them, or I'm going to grab a paper towel to collect but I'm not touching that hand wipe. Now, I'm going to wash my hands in just a minute, but still pretty high on my personal gross meter. I'm going to use a paper towel. Good? So we know all of these. Let's use it to check off this list. Now, the thing is, this is not a hard skill. It's really not. But man, there are a lot of steps. Let's take a look at how we're going to be graded. The first thing we're going to do is follow the care plan. We're going to do our opening and get those check marks. We're going to use gloves, absolutely, because this is body fluids. We're going to not go on break, no, not yet. We're going to use a barrier on our table. Now I'm going to time out here for just a second. I am training you to put a barrier on the table. For the test, you're going to use the table. You're going to put all your supplies on the table like we do for everything else. None of that changes. But in a clinical setting, there's a better way. This is their dining room table. This is where they're going to eat breakfast, lunch, and dinner. It's also going to hold their crossword puzzle books and their chapstick and their hairbrush, their water pitcher. I don't want a toileting item on here. Even if we're using a barrier, it's still just pretty icky. Would you be okay with a urine cup full of urine on your dining room table if it had a napkin under it? No, find another surface, please. Okay. So we're going to do this for the test because we're just following the steps that we've learned. But in a clinical setting, don't put the bedpan directly on the table. It has a home. It's happy in its home. It lives in the bottom drawer. Just open the drawer, leave it in the drawer until you're ready to use it, and then pull it out and put it right under the patient. Okay? I just don't like bedpans on tables, even with a barrier. It's just ick. We're going to do it for the test. It's fine. You can just leave it in there for the test. You can do that.
Until it's time to take it out.
Yeah, that's fine. That's fine. But I've trained you up until this point, and I'm all about consistency, so you don't have to learn anything new, right? I'm all about consistency. So get your barrier, put all your supplies on the barrier, just like we do for every other skill, fine for the test. In a clinical setting, just leave it in the drawer, please. All right. We're going to keep the patient in the middle of the bed at all times. That's important. We're going to clean our basin like we clean everything else. But look at how many steps are graded for bedpan. Yeah, this is a lot of steps. So everything that I've told you is a graded checkpoint for this skill. Okay? And then we're going to follow up with the closing. So any questions on bedpan? Do you guys understand why putting the head of the bed up is the most important step for this skill? All right. Remember, this care plan is only for this patient. This one goes to the bathroom by himself. This one has a bedside commode, and this one has a catheter. All different ways that we can urinate. All right. So Jake's going to show you this video, and then we're going to take our break. I got it, Jake.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I understand you need a bedpan. Can I help you with that?
Yes, please.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. After I've washed my hands, I'm going to get my supplies. I'll start with a barrier, unfolding it with the absorbent side facing up, and this is going to give me a clean place to put my clean supplies. And we're going to start with the chucks, and then I'll move over here to the patient environment. I need a set of gloves, a second set of gloves, hand wipes, and I'll need the bedpan, which will be in the bottom drawer. I'm going to open the drawer, but I'm not going to touch the bedpan until I put my gloves on. We'll go ahead and put the gloves on. I'll take the barrier and prepare it by holding it up with the absorbent side facing me, and I'm going to roll it toward me. And we're going to set that aside. I'll get the bedpan and the toilet paper out of the drawer, and we'll put those on the bedside table. Now we're ready to start the skill. Okay, Mr. Jones, I'm going to ask you in just a moment to bend your knees and put your feet flat on the bed, and you're going to lift your hips up for me so I can unroll this chucks underneath you. This is going to protect your bedding while you use the bedpan. Okay? So I'm just going to loosen this sheet up a little bit so we've got some working room. I'll take my prepared chucks, and we're going to place it on the bed where we're going to unroll it under the patient. It needs to be under the middle of the patient where the bedpan is going to go to protect the sheets from becoming soiled. Mr. Jones, can you bend your knees? And I want you to lift your hips as high as you can go. Thank you. I'll unroll that chucks all the way to the other end. Okay, you can relax. There you go. Now we're going to put the bedpan under the patient. The wider end of the bedpan goes under the patient's buttocks. So this will be toward the foot of the bed. Mr. Jones, can you lift for me? Thank you. Go ahead and come down. Make sure that that's centered appropriately. All right. And now I can remove this set of gloves. We'll throw these gloves away, and I'm going to put the head of the bed up. Mr. Jones, I'll put the head of the bed up now. That bedpan may shift a little bit. Feel free to move it as you need to and let me know when you're comfortable. And you can relax your legs. So you comfortable? Okay. Here's your toilet paper. Here's your call light. I'm just going to step on the other side of the curtain and let me know when you're done. Okay, Mr. Jones, are you done?
I am.
Very good. Let me lower the head of the bed. There we go. And I'm going to put my gloves on. All right, Mr. Jones, in just a moment, I'm going to ask you to bend your knees and lift your hips off of the bedpan. But wait until I tell you because I need to hold that bedpan flat.
Okay.
Okay? I'm just going to move this out of the way. I'll take a corner of the chucks. Go ahead and bend your knees. Don't lift yet. I'm going to take a corner of the chucks and hold the front of that bedpan down as he lifts. Go ahead and lift. And I'll pull the whole chucks and bedpan out. Relax. And we're going to take this to the bathroom for disposal. I'll bring the bedpan over to the patient bathroom area. We'll unwrap the chucks from around the bedpan and dispose of the chucks. And then we're going to dispose of the contents of the bedpan into the bedside commode. For testing, this is a simulation skill. There will not be anything in the bedpan, but we're still going to follow through with the simulation. We'll lift up both the seat and the lid. We're going to dispose of the contents of the bedpan into the bedside commode or toilet. And then we're going to rinse the bedpan. We want to put the rinse water into the commode as well. Now I'm going to set the bedpan down into the sink, disinfect it per facility policy, and then use a paper towel to pick it up. I'll take a paper towel to dry the inside. Throw that away. Another paper towel to dry the outside. Throw that away. And then one more for the drawer. Now that I've cleaned the bedpan, I'll get the toilet paper, place it in the bedpan, open the drawer with a paper towel, and then we're going to position this bedpan in the drawer and close the drawer with the paper towels. I'll then throw these paper towels away. We're going to remove the gloves and throw those away. I'll get a paper towel. Mr. Jones, I'm going to give you a hand wipe so you can wash your hands after using the bedpan. Go ahead and take a hand wipe. And then I'll collect that hand wipe after you're done with the paper towel.
Thank you.
This keeps me from touching the hand wipe. We'll throw this away. We're going to throw the barrier away. Clean our work environment. So I'll pull the sheet up. Make sure that it looks good. And here's your call light, Mr. Jones. If you need anything at all, just press that red button and we'll be happy to come back and help you. I'm going to remove your bedside table and open your privacy curtain. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Okay, your bed is in the low position. Your environment is clean. I'm going to go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. All right, any questions on that skill? Once you know why the important points are important, it's actually not a hard skill at all. Okay, just remember, bedpans are a last resort. Patients have a hard time using them. It may take a couple of tries. Be patient with them. All right, let's go ahead and take our break. And when we get back, we'll go through the last two skills. All right. Thank you. Jake, do you know where my drainage bag is?
Believe it may be still set up with Miss Jones.
Oh, okay. All
Because
right.
it was on the bed.
Just make a note. We need a second one in here so that one stays on the bed.
Okay.
Thank you. And zip tie, please.
I'm sorry.
Zip tie for the call light. Okay. Moving on. These are the last two skills, and we're going to learn these two skills together, back to back, okay? And then I'll show you both videos. So I'm going to talk to you about catheters. We're going to learn about catheter care. I'm going to talk to you about the bags because they kind of go together. And we're going to learn about emptying the drainage bag and measuring and recording. And then I'll show you those two videos together. They're two separate skills. So catheter care is one skill. Emptying the drainage bag is another skill. They are two separate skills for the exam, but in a clinical setting, they're going to go together. And then after that, we're going to have some practice time. So if you're looking on page 158, down here are step-by-step principles. Over here, they're all spelled out for us. We have skill-specific steps we're going to learn in just a minute. And down here is our test-specific information. So somebody with your level of experience, which is none, should be able to do this skill in 15 minutes or less. This is going to be done on a mannequin for the exam. That mannequin will be positioned in bed. This is not a documentation skill. The next one is, but not this one. When you're looking at page 159, we have step-by-step instructions listed, care plan at the top, supplies at the bottom. Let's look at the care plan. It says provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Let's stop there for a second. Catheters can be used on males as well. It's the same catheter. It's the same process. It just goes through a little more tissue. Nothing else is different. So catheter care is going to be done on females and males. And cleaning the catheter part is the same. We're going to use peri-care techniques based on whether it's a female or a male. Okay? So catheters can be inserted in both. It's the same catheter. It's the same process. Good. For the test, we're going to use a female mannequin because the risk of infection is much higher in females. It says clean the catheter tubing and perineal area only. So it tells us exactly what to clean. The tubing and the front of the patient, the peri area. Questions? Do you guys remember peri-care that we learned last class? We changed the chucks under them. We cleaned top to bottom, middle, side, skin fold, skin fold. Whatever we washed, we rinsed. Whatever rinsed, we dried. Then we turned the patient over and cleaned the back side. Up the center crease, cheek, center crease. And then we changed the chucks again. Remember peri-care, right? Those are the main steps of peri-care. Good? Because catheter care is very, very similar. But instead of starting out with the chucks under the patient, there won't be one. So we're not going to change the chucks. We're going to place a chucks. We're going to clean the peri area the same way we did for peri-care. It's the same cleaning. Same cleaning. But instead of cleaning the backside like we did with peri-care, instead of cleaning the backside, because this backside has been laying in urine. It needs to be cleaned. Instead of cleaning the backside for catheter care, we're going to clean the tubing because this patient isn't laying in urine. The urine is in a bag. So peri-care, front and back. Catheter care, front and tube. Good? Good? Okay. we're going to remove the chucks at the end of the skill. Don't leave a chucks under somebody if we don't need it. Chucks are there to absorb urine. If the patient isn't leaking urine, in this case, the urine's in a bag. If the patient isn't leaking urine, we don't need a chucks. Why wouldn't we use a chucks on everybody? Well, number one, cost. But number two, these are plastic lined. That means they're going to hold in body heat against the patient. We now have warm, dark, moist. We don't want to, and the patient's going to sweat because it's holding in body heat. We don't want to leave a chucks under a patient if we don't need one for absorption. Good? So we put the chucks there to keep the sheets dry as we're cleaning, but for this skill, we're going to take it away. So what's different with catheter care versus peri-care is that we're not washing the backside. We're washing the tubing instead. And we're not leaving them on a chucks at the end. We're going to place and remove instead of change and change. Other than that, you already know this skill. Good? Good. So it's not nearly as hard as you think it's going to be. But in order to understand catheter care, we have to learn a little bit about catheters themselves. So what I'm going to teach you now is a very brief understanding of catheters, how they work, responsibilities, and infection risks. So that's what we're going to cover here in the next couple of minutes. So catheters are inserted and removed by nurses, period. CNAs are not putting them in. CNAs are not taking them out unless you have received additional training. Okay. In some settings, you may be trained to remove a catheter. Super easy. But you may be trained if it's part of your job requirements for that setting. Remember, you can be trained to do anything a nurse does. That's delegation. But for our standpoint right now, CNAs do not put them in and CNAs do not take them out. Questions? All right, so this is a catheter. This is what a catheter looks like. It's a straw. This catheter is no different than the straw in this cup. It's hollow. Liquid goes through it. There is no difference between the two, other than my straw in my cup has an open top so I can drink through it. This straw has a closed top and the openings are on the side. That's it. That's the only difference between a catheter and a straw. And it used to be over 100 years ago, we actually used straws. They were glass. Yeah. But we found that they're a little hard to put in. So they decided, hey, if we made the tip blunt and closed it, it'd be easier to put in. Let's take the hole from the top and put it on the sides. So we did, and that created our modern catheter. So all a catheter is a hollow tube that is going to direct urine out of the bladder. That's it. That's all a catheter is. It is a hollow tube that directs urine out of the bladder. There's nothing scary about it. We put it in a hole that's already there. We're not drilling anything. There's no incisions. There's no crazy stuff. The hole is there. Anybody have pierced ears? You put an earring in through a hole that is already there. Is that scary? Okay, we're putting a catheter through a hole that's already there. It is no different than putting earrings in your ears. Yeah, me either, but still, we're going to talk about that. Okay, so do you understand that this is not as scary as your brain wants to make it? It is a straw we're putting through a hole that is already in the body. Now, when we put the straw in, it looks like this. It's all kind of collapsed. But if I put this in the body and then let go of it, that's exactly what it's going to do. It's going to fall right out. That doesn't help us. So when we put a catheter into the urethra and we advance it up, we have to have a way of keeping it in the bladder. So we're going to take some water. I need one more hand here. We're going to take some water and we're going to blow up a little balloon on the end. And that balloon sits right there just above the valve. You guys remember the valve we talked about last class? This balloon right here sits just above that valve and it keeps the catheter from coming out. So now if I let go of the catheter, that balloon is going to keep it in place. Now, if I want to remove the catheter, it's time for it to come out. The patient doesn't need it anymore. Then I'm going to take a syringe, remove the water. And remember what happened when I let go of the catheter when there wasn't any water in the balloon? The catheter comes out. So CNAs can be trained to take catheters out. You just take the water out of the balloon and it comes right out. Good? Are you less scared of catheters now? That's all a catheter is. A hollow tube that lets urine out of the bladder, and it has a little balloon that's designed to keep it where we want it. That balloon is inflated and deflated with water. Yeah. Questions? All right. So that's what I just showed you. To remove a catheter, we have a catheter in the bladder. The balloon is inflated to keep it there. It's time for it to come out. We're going to deflate the balloon, take the water out with a syringe, deflate that balloon. The balloon deflates, and then the catheter literally just slides right out. It does not hurt. If it hurts the patient when you take it out, you did not deflate the balloon. Now, can you imagine this balloon going through this tube? Do you see the size difference there? Okay, that's going to hurt because we're stretching the urethra. It's got to stretch around that balloon. That's going to hurt. So if you're removing a catheter and it hurts, just remember, you forgot a step. Yes, just like this. No, because it's, how do I put this? This isn't a really good picture representation. It does kind of have a downward turn, but it's more like, you guys don't know about heart valves yet. It's more, kind of more like this, not like this. Okay, this is an exaggeration just for your own. Yeah, it's not. Think about your rectal opening, okay? It's mainly designed to let stuff out, but we can put suppositories in, okay? I wouldn't call it comfortable, but it's not painful, okay? It's designed to move in a specific direction, but it doesn't mean it can't move the other way. Make sense? Okay. All right, so what are CNAs responsible for? I just wanted to show you that so that you understood the internal mechanisms of how a catheter works. Remember, CNAs don't take them out. You don't put them in. You have to have additional training for that. But I just want to make you understand that they're not as scary as they seem. Because if you're afraid of catheters, you won't clean them right. Okay? So what are CNAs responsible for? We clean them. We clean the tubing. We clean the skin around the tubing, usually once a shift or as directed on our care plan. That's what we do. That's our job, is to clean the catheter and the skin. That's it. Good? Now, catheters are attached to bags. A catheter alone, if I put this in a patient, right, this part's in a bladder, urine is coming out. That doesn't do us any good because now we got urine everywhere. It's just going to go everywhere. That doesn't help us a bit. So we need this attached to some sort of a collection device, a bag of some sort. Now, this bag cannot touch the floor. Remember our rule? The only thing that touches the floor is, does this touch the floor? We have to look. Is it on the floor? If it is, we got to let the nurse know. We got to change that. Pull it up. Don't let it touch the floor. We also want to make sure the tubing isn't kinked. If the patient's laying on the tubing and it's all kinked shut, no urine can come through. So just take a look. So we clean the catheter tubing, we clean the skin around the catheter, and we look at the bag. Those are our responsibilities as a CNA. We're also going to learn how to empty the bag, next skill coming up. Good? So this is called a closed system. A closed system means that bacteria cannot enter it naturally. They have to have a doorway opened for them to get in. They can't get in all by themselves, okay? Remember, they don't drill. You guys remember that? No jackhammers? Okay. So the closed system means that this end is inside the patient. The inside of the tubing connects to a bag that connects to, or I'm sorry, the catheter connects to tubing that connects to a bag. None of this is open. None of this allows pathogens in. There's only 3 places that pathogens can enter this system. The first one is way up here, when the nurse puts the catheter in. Okay, let me go back here. I've got a slide on this, but I think it's further back. Where the catheter is inserted into the body, if the nurse isn't careful, she can bring pathogens with her. That's not a good idea. This is why CNAs generally aren't putting catheters in, even with training, because the risk of introducing bacteria pretty high. We can separate these two, and when we separate these two, it can introduce pathogens. And then we can open this to empty the bag, and if we're not careful, we can introduce pathogens. So this is a closed system, but there's 3 places that if we open the system, pathogens can enter. This one, not a CNA problem. This one, a CNA problem with training. I'll get to that in a minute. And this one, definitely a CNA problem. But, because we're going to empty this bag. But this is as far away from the patient as you can get. So lowest risk. Good? Good? All right. So the catheter and the bag are 2 separate pieces. Here I have a catheter. Here I have a bag. 2 separate pieces. And we do that on purpose. Because this catheter, this catheter can stay in place for up to 30 days before it has to be changed. So we have people, we have people with long-term catheters, which means we change them out once a month. They can stay in place up to 30 days. The bag itself, we don't want a urine bag to be used for 30 days. It's like not cleaning your toilet for 30 days. That's pretty gross. So this can be changed out much more frequently, usually once a week. So if we have something that can stay in place for 30 days and something that has to be changed once a week, they have to be 2 separate pieces. CNAs do not change the bag without additional training. You can be trained though. It's perfectly okay. It literally just plugs in. So, as CNAs, we clean and inspect the bag. We empty the bag and document output, but we can also be trained on changing the bag. This is as simple as unplugging the bag and plugging in a new one. But remember I said there's 3 places that pathogens can enter the system. Up here, which is a nurse problem. Here, which could be a CNA problem, and down here, which is definitely a CNA problem. We weren't worried about this as much because it's further away from the body. Not as much space for the pathogens to have, or more space for the pathogens to have to climb to get to the bladder. But when we are talking about this is way closer to the body. If we let pathogens in, it is a risk to the patient. That's why you need additional training. Now, one of the most common mistakes for this skill on the state exam is CNAs unplugging the bag to clean the catheter. They try to clean the inside part of this catheter. Not our job. We do not unhook this without additional training. Or CNAs will unhook the bag in the next skill and carry that bag to the bathroom to drain it. That's not proper procedure. These two pieces do not get disconnected unless the care plan specifically tells you to and you have been trained. Good? You guys remember this? This is the chain of infection, right? Catheter-acquired urinary tract infections, or what we call CAUTIs, you'll hear that term a lot, CAUTI, C-A-U-T-I, is the #1 healthcare-acquired infection in clinical settings. So that means that patients with catheters are at risk of developing something they did not come in with. And these are dangerous. These are not your run-of-the-mill UTIs. They are not the run-of-the-mill, and I'm going to show you why. But CAUTIs kill a lot of people every year. Can you imagine getting COVID and going to the hospital and having to deal with all of COVID stuff and your, lungs are affected and you're on all kinds of medication and you're on a ventilator. And because you can't get up and go to the bathroom, we're going to put a catheter in you. And COVID doesn't kill you. You're able to recover from COVID. What kills you is the infection from the catheter. Happens all the time. So when we're talking about catheters, this is a direct pathway into the body, but more specifically into the blood. Because remember our urethra here attaches to the bladder. The bladder attaches to the kidneys. What do the kidneys do? Filter. What are they filtering? What body fluid? Blood. Blood. Pathogens that get here can get here, and then they go into the blood. You see how that could be a problem? And there's nothing there to stop it. Nothing. Nothing. Once pathogens get here, our white blood cells have very limited effect because they're in acid. White blood cells don't like acid. That'd be like me dropping a quarter in a vat of acid and saying, hey, go diving. That quarter's not worth it to you. You're not going to go diving. You're going to leave it there. Yeah, that's what happens here. When pathogens get into the bladder, we don't have a lot of defenses against that. So they just multiply and multiply and multiply. They run out of room. Well, what are the 2 exit points? Your ureters. So they climb and they climb and they jump out into the kidneys. And man, that is nirvana. That is a great opportunity for them. And then it's just a matter of going through a small little membrane and getting into the blood. And now they're circulating throughout the entire body. And it's probably going to kill the patient. These are not risk-free. And that's why I said earlier that if somebody can't go to the bathroom, it's not an automatic catheter. We only use catheters when we absolutely have no other options. Now, this is a big change because back in the 70s and 80s, when you went to the hospital, didn't matter what you went for. You got an IV and a catheter. I mean, we just put them in everybody. It was like, cover charge. And we started to realize that, hey, these people that were like not too bad are dying. What's happening? And it took us a while to put these pieces together. So now catheters are only used when there is a legitimate reason for it, not convenience. Now, there's still a lot of healthcare people that think catheters are convenience. I don't want to take the patient to the bathroom. They're slow, they're weak, they're a fall risk. So if we put a catheter in, we can just keep them in bed. Does that help the patient? Who did that help? The staff. So when I said it's all about the patient, did I say it's all about the staff? Who did I say it was all about? So we better be making decisions that are truly all about the, not ourselves. That's the problem here. Every decision a nurse makes, those of you that go on to nursing, every decision you make should always meet that benchmark. Is this benefiting the patient or is this benefiting the staff? Every decision. And we make the wrong ones all the time. All right. So when we have this system and we need a catheter, we're going to put the catheter in through the urethra, get it past this valve, and we know we're past the valve because we start seeing urine, right? Because remember, urine is on the other side of the valve. So we insert the catheter, we see urine, we know we're in the bladder, and then we inflate that balloon to keep it there. That catheter is going to be attached to a bag. So urine produced by the kidneys goes down the ureters into the bladder. This little hole on the side of the catheter is going to let that urine go through the catheter tubing, into the drainage bag tubing, and ultimately into the bag. That's how the system works. Now, as CNAs, we empty this bag. So that means that we have to open the system way down here, but we're still going to open the system. When we open the system, if we let pathogens into this bag, this is important because the next skill is all about opening the system. If we make a mistake and let pathogens into this bag, they are now in a liquid. But it's not just a liquid, it is a warm liquid. And it has proteins and enzymes that these pathogens need to procreate. Now, remember that pathogens don't need little boy pathogens and little girl pathogens to make baby pathogens. Doesn't work like that. They don't procreate like we do. Pathogens need the right conditions, and then they zip themselves in half, and now there's two. Now, watch how quickly this can escalate. This is called exponential growth. So if I start out with just one little old lonely pathogen, no big deal, just one. But I give it the right conditions and it zips himself apart, and now I have two. Still not a threat. There's only two pathogens. They're little, they're small, they're far away, not a problem. But in a few minutes, those two become four. Still, not much to worry about. A few minutes later, those four are now 8. Oh, wait, I started with 1. And it's only been 2 minutes. And now I've got 8. But they're still quite a ways away. So a minute later, that 8 is now 16. That 16 in the next minute turns into 32. That 32 in the next minute becomes 64. And then that 64 in the next minute becomes 128. A minute later, 256. A minute later, 512. A minute later, 1064. So we started with one pathogen. And in a very short time, we now have over 1,000. They don't procreate like we do. We think growth is slow because it takes us 9 months and we usually only have 1. It takes 2 of us to make 1 offspring. That's not how this works. Good? Good. All right, so now we made a mistake. We let 1 pathogen into this bag, and before long, we now have 1,000. Doesn't take long. Well, that 1,000 is going to multiply, and now we've got 2,000, and that's going to multiply. Now we got 4,000, and that's going to multiply. Now we got 8,000, and they run out of space. There's just not enough room in that bag. So they start to climb. And they get into the tubing, and they start to climb. And they get into the catheter, and man, this is the best place because now the urine is really hot, and it's fresh food. So now they're really ramping up. And as they climb, because the numbers are just so overwhelming and they're out of space, and they jump out into the bladder, it's not 1 or 2 bacteria that is jumping out. It is 1 or 2 trillion. That quick. It is an overwhelming invasion with no way of stopping. Because we don't have any defenses inside the catheter. Do you understand how critical preventing these invasions are? Okay. All right. So once they get into the bladder, it's a hop, skip, and a jump to the kidneys, and then it's pretty much all over. So there's 3, and I knew I had a 3 entry point one here. There's 3 places this can happen. Up here, that's the nurse's problem. Here, that could be your problem with training, or here, definitely your problem. So when we're changing this, or I'm sorry, when we're emptying this bag, we need to be very, very careful not to let that port touch anything. Nothing. Not your gloves, not the bed, not the container, not the chucks, not the bag, nothing. That port that we're emptying the urine from can touch nothing, because anything it touches allows bacteria into that bag. Are we clear? All right. So bags need to be hanging on a non-moving part of the bed above the floor. If that bag is on the floor, it's coming into contact with pathogens. When we open that port, where do you think the pathogens are going to go? So that's why the bag cannot touch the floor. Good. We also don't want that bag above the level of the patient's hips, because recycled urine is gross. If you raise that bag up, whatever's in that tubing is going to run right back into the patient. And urine really should be a one-way trip. But any pathogens that are in the catheter are going to be swept like a water slide right into the bladder. So we never raise the bag above the level of the patient's hips. Now, I watch a lot of like Discovery Health shows, and it amazes me how many shows on TV, like they know they're on camera, are walking a patient down a hallway holding the bag up. Ew, don't do that. The bag should be below the hips. All right. The tubing should not hang off the bed. The tubing should coil on the bed itself, because when the tubing hangs off the bed, like down here, what you see here, then the patient's feet, the staff feet, the visitor's feet can get all tangled up in that tubing and accidentally pull it out. And they'll pull the catheter out. Absolutely. In fact, staff pulls out way more catheters than patients do. This is just one way. We're going to talk about some others. Patients do pull them out. Usually when your patient is confused, they'll pull out a catheter. It does happen. If you catch a patient tugging on a catheter, who should know? The nurse, absolutely. So yeah, they will pull them out occasionally. Not a good idea. And this is why we only use catheters when we absolutely, positively have no other option. They're uncomfortable. They don't belong. They feel weird. They shouldn't hurt. If it hurts, you need to let the nurse know right away, because that there is a condition that can cause that. So if the patient's like, ow, 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 it hurts, let the nurse know right away. But patients that are tugging on a catheter are at risk of pulling it out. So we want to let the nurse know. But the real problem here are CNAs. CNAs will turn a patient over in bed And when we do that, we generally lean against the mattress. Well, if the catheter tubing is right there between our leg and the mattress, we're holding it in place while we're turning the patient. We will pull that catheter right out of them. When we get a patient out of bed and into a wheelchair, if the catheter bag is on the other side of the bed, it's gonna get pulled out. When we take a patient for a walk, when we stand them up, if that bag is on the chair, it's gonna stay on the chair. We do this way more than patients do. Now, the problem is CNAs are afraid they're going to get in trouble. They accidentally pull the catheter out. They don't want anybody to know, so they kind of hide it until the next shift. Let somebody else find it. Let it be somebody else's problem. I don't want to get yelled at. Guys, if you pulled a catheter out, you deserve to be yelled at. Because you know how important this is. You've heard this lecture. If you aren't taking care, you deserve the lecture. Responsibility, right? This is your opportunity to say, yeah, I screwed up. Absolutely. That won't happen again. Learned my lesson. But don't hide it. And this is why. Have you ever had an injury? Have you ever like banged your thumb or had it shut in a car door or something like that? Have you ever had an injury? Whenever there's an injury, there's always swelling. Always. Because we're trying to push healing blood and white blood cells to the area, some platelets to stop any bleeding, right? We're flooding the area with blood, so we get swelling. This is one place you probably don't want swelling. But the real problem is, as a nurse, if I have to put another catheter in and there's swelling, it's not going to happen. I'm not going to be able to get through that. So now this patient is stuck without a catheter and their urethra probably tore a little bit when that balloon this big went through a space this big, right? So it's torn, little bleeding, a little, mucus, right? But do you know what that's going to feel like peeing through it? So it's swollen. I can't get another catheter in and it's going to burn like mad. Is this a good situation for our patient? So if you hide this, your patient is the one that's going to pay the price. Now, the real problem is I no longer have an option. I can't put another catheter in until that swelling goes down. I am out of options. Patient is now stuck with what they're dealing with. That's a horrible choice to make for the patient. So if a catheter gets pulled out by the patient, by you, I don't care. Who should you tell right away? Yeah, I've got about 45 minutes to get another catheter in before the swelling is so bad that that's not a possibility. Now, if you take that 45 minutes from me, I'm going to be very upset at you. Because my patient's the one that's going to pay for that. Make sense? Okay. If a catheter does come out, if you pull it out, patient pulls out, doesn't matter. If a catheter does come out, we got to figure out what to do with it. Don't throw it away. Like, I don't want you to throw it in a trash can. What I want you to do is get a clean trash bag, and they're always in the bottom of the trash cans. So take the trash bag out that's in there. There's always some clean ones in the bottom. Grab a clean trash bag, open it up, and just put the catheter and the bag itself in that clean bag. So that's all I want in the bag. Clean bag, the catheter that came out attached to the catheter bag, put it in the bathroom. Come find the nurse. Hey, catheter came out. It is in a bag in the bathroom for your inspection. Now, this is critical. If a catheter comes out and the balloon is intact, it's still inflated, it's all there, that's okay. That's something I can deal with. That's fine. But if the catheter comes out and the balloon is deflated, if it's busted, that means a piece of it may still be in the patient. That's not a problem a nurse can deal with. We now have to talk to the surgeon. We're probably going to have to put a scope up there with little grabby things and go fishing. So I need to know, the only way for me to know what I'm dealing with is to look at the balloon. When I look at the balloon, if it's intact, okay, I can document that. Catheter pulled out by the patient, balloon intact, MD notified. So, now the doctor knows, we know what we're dealing with. There's nothing left behind. If I look at that balloon and it's not intact, then I'm going to document that. Balloon not intact. And then I'm probably going to say, but margins aligned, which means that it doesn't look like there's anything left in the patient. Or I may say margins unaligned. That means that something was left in the patient. And I've got to let the doctor know about that too.
How in the world can we, pull out the balloon? It's like the balloon is, as you said, is this big, and the tube is.
Okay. So this is the size of your urethra. This is the balloon.
Yeah, it's too much. It could be very painful for the patient.
This compresses. That's as easy as it is. That's it. That's it. Because you're not talking about, your urethra is not steel. It's flexible. It's not rigid. It's tissue. It's flexible. So yeah, when we bless you, when we tug on this, I mean, it'll hold, quite a bit of tugging, right? Because that valve is there. It'll hold up against quite a bit of tugging, but you tug enough and it's going to push through that valve. It's just a valve. Yeah, yeah. So I'm going to pass this around, but you can see just how squishy this is. It's a balloon. It's a balloon. I'm going to pass this around in a minute. So what do we do when a catheter comes out? We put it in a bag and we let the nurse know right away. Now, there's a couple different types of catheters. And it's important that CNAs kind of understand a little bit about each type. So this is the one we've been working with. It has a balloon, and it actually has 3 names. It is called an indwelling catheter. It is called a Foley catheter because the guy that invented its name was Foley. But it's also just called a catheter, right? When we talk about catheters, this is the one we're most commonly talking about, the one with the balloon. But we don't always need to put a catheter in and leave it there, right? The balloon is just there so it doesn't come out. We're leaving it there. In some cases, we just need to put it in to empty the bladder, then we're going to take it out. We're not leaving it there. We're just putting in for a very short time specific purpose. So in that case, we're not going to use one with a balloon. We don't need the balloon. It's not staying. We're going to use one without a balloon. It's the exact same thing, just no balloon. But we do have a different color just to help identify it pretty quickly. This is called a Red Robinson, also known as a straight cath or an intermittent cath, but it just doesn't have a balloon. That's the only difference between these two. It doesn't have a balloon. And because it doesn't have a balloon, see how this has 2 ports? One for the bag, one to inflate and deflate the balloon. This one doesn't have a balloon, so it's just 1 port. Good? Then we have a third type of catheter called an external catheter, and this is only for men. We use this for men. And it's also called a condom cath or a Texas cath. I don't know why on the Texas part. But it's called a condom cath because it goes on just like a condom. So you prep the skin, you put it on, the inside is sticky, and it's designed to stay in place for up to 3 days. So this goes directly on the shaft, and the tip stops like right about here. So that means we've got this little reservoir here, which is going to allow urine to kind of stay right up against the tip of the penis. So we're going to change this every 3 days and do really, really, really good peri-care. We want to clean all of that off the skin. Most of the time, if we have a condom cath, your care plan is going to tell you to apply something called skin prep. Looks just like an alcohol pad. Identical to an alcohol pad, but it's a different color package. And we just wipe that on. It's not alcohol. It's actually a barrier. It's like putting saran wrap okay? Liquid saran wrap on the tip. And it just helps provide a barrier between the urine and the skin. This works the same way. You see how this has a connection port to connect to the bag? See how this has a connection port? This also has a connection port. So the bag just plugs right in. So how does that work? Well, if I have a bag and my bag has a port and I have a catheter and it has a port, this port just plugs right into this one. That's it. That's all that's required. You have to be trained to do that because when I open this up, I could introduce pathogens. So we have to be able to do this in a very clean way where we're not introduced. The mechanics of it's super easy. You just plug it in. That's it. It's not that you need training for that. Anybody could figure that part out. It's the fact that we want to plug it in without letting pathogens in. That's why you need training. Good? Okay. Start over here. You can take a look at the catheter and the bag. Oh, let me, here, I'll pass the syringe around so you guys can play with that as well. All right, so to do catheter care, to clean the skin, we're just going to hold that catheter up out of the way. That's all we're going to do. Just hold it up just so we can clean the skin. So we hold it up out of the way. We clean with 5 leaves, middle, side, side, skin fold, skin fold. We've seen this before. There's no difference here. We're just holding the catheter out of the way when we do it. Whatever we wash,
We dry.
no, rinse.
I'm sorry.
And whatever we rinse, we dry. So we're going to use all 5 strokes. Middle, side, side, skin fold, always moving top to bottom, never back up. Now, when we're ready to clean the tubing, we don't want to pull on it inside the body. So we're going to just take our finger and thumb and hold it where it exits the body and then clean the tubing away from the body. But when you hold it there, you can, use some friction to clean that tubing. It's not pulling on the inside of the body. You're holding it steady. We're going to use 4 leaves for this. So we're going to hold it, take 1 leaf, wrap it around the catheter, wipe away from the body, and then we'll fold that leaf. We'll hold it, wipe away from the body, fold that leaf. Hold it, wipe away from the body, fold that leaf, and hold it, wipe away from the body, and put it to the side. Whatever we wash, we rinse. Whatever we rinse, we dry. Then you'll take that pad out from under them. That's it. That's the whole skill. That's it. So we now know all of the principles that we need to know to do this particular skill. Let's go through the skill-specific steps real quick. So we're going to unroll the chucks under the patient, putting it there to keep the bedding dry. We're going to clean the peri area using the 5 leaves. We're going to wash, then rinse, then dry, top to bottom, never moving back up. Just like peri care, wash, rinse, dry. Then we're going to hold the tubing, the catheter itself, wipe away from the body. And again, we're going to wash, rinse, and dry. And then once we're all done, we'll remove that chucks. We're going to take a look at that tubing, make sure it's not coiled near the floor where our feet can get tangled in it. Make sure it's hanging from a non-moving part of the bed and it's not kinked. Just look at the tubing, make sure everything is good. Good? So let's see how we're going to use these principles to check off this checklist. We're going to follow our care plan. We're going to do our opening. We're going to wear gloves because we're in a personal area and there's body fluids. We're going to use a barrier on our table. We're not taking a break. We're going to use a privacy blanket because we do have to uncover the patient. We're going to keep the patient in the middle of the bed, and we're going to use our washing skills. We're not going to add soap to the basin. We're going to check the water. They're going to check the water. Whatever we wash, we rinse. Whatever we rinse, we dry. All of those steps. We're going to clean the basin like we clean everything else. And we're going to do our skill-specific steps. So you remember bedpan? There was a lot of skill-specific steps. There's not very many for this skill. And the ones that there are, you know already. Then we're going to do our closing. Is there any questions on this particular skill? I'm not going to show you the video right this minute. Remember, this skill is only for this patient. These guys, they have different care plans for catheters. I'm not going to show you this video right now. We're going to roll right into emptying that bag. And then once I'm done with this lecture, I'll show you both of the videos together and give you the rest of the class for practice. Okay? So if you go to page 164, we know the drill here. We have our principles down the side. We have our skill-specific steps. Principles are all laid out for us here. And down here is our test information. So somebody with your level of experience should be able to do this in 9 minutes or less. This is way more time than you need. This is a 3-minute skill at best. Way more time than you need here. They should take a few of these minutes and put them on denture care, I think. This is going to be done on a mannequin. So talk to the mannequin like you would a regular person. Mannequin will be in bed, and this is a documentation skill. So we have to learn about the documenting part of this skill. Page 165 has our care plan at the top, has step-by-step instructions and supplies at the bottom. Let's look at this care plan together. Empty the resident's urinary drainage bag into a graduate container and measure and record urinary output in mLs or cc's. Remember, mLs and cc's are the same. You guys remember that? So it says use the container that has these markings to measure the urine. It does not say to measure the urine using the bag. So if you look at that bag, you're going to see, thank you. If you look at this bag, you're going to see that it has measurement markings. It has measurement markings. We do not use these to measure urine. This is for the nurse to eyeball. This is for a quick reference for nurses. CNAs do not use this. If CNAs are measuring urine, we have to take it out of this bag, put it into a cup, and really measure it. Really, for real, measure it. Okay? All right. It also tells us to document it on the intake and output form. So if you keep your finger here and go back to page 169, you will see the intake and output form. We've seen these before. But if you go back to page 165, right here in the middle of the page, you can see a completed form. This is the critical part of this skill. Is urine intake or output? Does it go into the body or does it come out of the body? Out. If you document urine in the intake portion of this form, you are legally declaring, hand on the Bible, that this patient drank urine. That is what you are legally declaring. Now, when the lawyer comes for you, and they will, and you say something like, well, you know what I meant, nobody drinks urine, that lawyer is going to say, you don't know that. That's not what this legal document says. You legally declared that this patient took in urine. How do you defend against that? You don't. Yeah, and now this patient is going to get a couple $100,000 for your mistake, documenting in the wrong box. So when I see online, and I do see online a lot, I took the test and I failed because I put it in the wrong box. Why didn't the evaluator give me a break? Well, because that mistake just cost the hospital a couple $100,000. That's why the evaluator did not give you a break. The test is not about you. It's not about what box you pick to put a number in. It's about the effect of that box on healthcare. Good. You have to understand how the test is structured. The test is not about you checking off boxes. It's about the box's effect on the patient. That's why my students do well. Questions? Okay. So what do we need to know? Well, there's a couple of different types of bags. Just like we had a couple of different types of catheters, there are a couple of different types of bags too. And it really depends on what the patient needs. So in most clinical settings, like long-term settings, you're going to have the big bag that I passed around in here because it holds a lot of urine. Big bag. We usually only empty it about once a shift. It holds a lot. But if we have a patient that's wandering around our community, if they're in Walmart or in Winn-Dixie or at Walt Disney World, they don't want to carry a suitcase of urine with them. It attracts a bit of attention. So that's just not cool. So we don't want obvious urine bags in those situations. In that case, we're going to use something much more discreet called a leg bag. Now, leg bags can actually be hidden under clothing very easily. They don't hold as much, but they can be strapped to the inside of the thigh or the inside of the calf and hidden with pants or skirts or dresses or something that makes it less obvious.
Can you use the number on the bag?
No. If you are, so let me put this in a little bit different way for you. Do you ever cook? Okay, so if you're following a recipe and the recipe says 3/4 cup milk, do you just look at the carton and eyeball it? Okay. All right, so we can't do that. If we need 3/4 cup milk, we need 3/4 cup milk. We need to pull the measuring cup out and measure it. That's the same thing here. This is the carton. We need to pull it out into a cup and measure it. Okay? Make sense? So we don't ever use the numbers on the bag. That's not for CNAs at all. And honestly, the nurses hardly ever use it either. It's just an eyeball. Like if I just happen to see this bag is full and we just emptied it an hour ago, that's not normal. Okay, that's not normal. But I can't call the doctor and say, yeah, it's not normal. I have to call the doctor and say, we've already removed 600 cc's from this patient, and I got another 600 in the bag after an hour. Those are hard. That's something the doctor, it's an estimation, right? I didn't pull it out and say 625, it's an estimation, but it gets me pretty close so that I can report it on to the people that can make the decisions.
Can an incontinent patient get one of these, a catheter?
Yeah, an incontinent patient can get a catheter, but we're increasing their risk of dying. And why would we do that when we could just clean them every 2 hours around the clock? So yes, we can put a catheter in anybody, continent or incontinent. I mean, we can, but we have to weigh the risks. And incontinence doesn't kill you. Catheters can. So which one am I likely to choose? Yeah, probably just clean every 2 hours around the clock. Now, we do have something relatively new that we can use. Remember how we have an external catheter or condom cath for men, right? So we use that for incontinence with men, but it doesn't have the same risk because it's not inside the body. We have something similar for women now called an automated collection device, or it's actually called a PureWick. And if you look on page 155, 155, it talks about automated collection devices. And it's basically like a soft cotton, think of it kind of like a tampon that we lay externally. We don't put it in, we just lay it externally, but it's connected to a suction hose. So it just pulls the urine away from the skin. It's external as well. So men have condom casts that are external. Women have a pure wick that is external. And that's how we a lot of times handle incontinence. Now, about 10 years ago, pure wicks were much more common. They found that there are some risks with pure wicks that we didn't know initially as well. Ideally, I gotta move on. Ideally, when we have incontinent patients, it's not about putting catheters in, using pure wicks. We are going to clean and change them every 2 hours around the clock. But ideally, what we want to do is get that valve working again, get them continent. And that actually can be done. The valve is a muscle like any other muscle. If I spend my entire life on the couch, my muscles are going to get flabby. They're not going to work very well. They're going to be very weak. But if I got myself off that couch and I started doing some squats and I started doing some bicep curls and then I started walking and then I started running, those muscles that were very flabby are going to slowly strengthen and come back online, right? They're going to do what they were designed to do. Just takes a little work on my part. Same thing with the muscle at the bottom of the bladder, that valve. It's a muscle. So when a patient's incontinent, it's flabby, it's not really doing a whole lot. But if we get the patient on a toileting schedule every 2 hours around the clock, we're waking them up at 2 a.m. and getting them to the toilet. But we had to wake them up at 2 a.m. anyway and clean them. So while we're cleaning them, we're going to get them out of bed, walk them to the toilet, sit them down. Just that act of sitting down on the toilet, even incontinent, reminds that valve that it had a job to do at one point. And then we get them up, we clean them up, we take them back to bed. 2 hours later, we get them up, we take them back to the toilet, and we try again. And if we do this every single day, 2 hours around the clock, we don't miss a single one. Usually about a week, we have about 80% continence restored. Now, what it requires, though, is every single member on every single shift to be diligent in doing this. Which means that we need good CNAs that understand patient dignity is important. And it's not about them, it's about the patient. Do you see why I do what I do? Because there's a lot of CNAs out there that really need to be sitting in these chairs. All right. So the goal here is to restore continence, not to deal with incontinence. That's what we would like to do. Now, this isn't always a possibility. In end-stage dementia, our patients aren't walking. There's no way of getting them to a toilet. We're not going to retrain anything. Everything is shutting down, not, being restored. So there are situations where this is absolutely not appropriate. It's not going to be fruitful. And the nurse's job is to separate who we can intervene with and who we can't. And the ones that we can, we'll put them on a bowel and bladder retraining program. All right. So when a patient is in bed or more sedentary, we usually use the bigger bag because they're not out roaming the countryside. But if the patient is in the public, we usually will switch them over to a leg bag. Now, remember I said that you can be trained in changing the bag. This is one of those situations. If you're working in home health and you're working with a patient who has a catheter, and you would be shocked how many people in our community actually have catheters. You have no idea. They're in Walmart right now. Right now. You have no idea because the catheters are hidden under the clothing. But it's a little more common in our community than you would think. It's not because of incontinence. A lot of older men had a prostate surgery done. And when we do a prostate surgery, there's some nerves that accidentally can get affected, get cut. One of those nerves is the one that controls the valve. So that's a risk of this surgery is incontinence. But if you have prostate cancer, we got to get rid of the prostate, so the risk may be worth the reward. So yeah, you have quite a few of these. You also have people that have had a stroke. Now, the stroke happens way up here. It doesn't happen anywhere near the bladder. How in the world does incontinence happen with a stroke? Well, because the stroke is in the brain. The brain controls the nerves. The valve can only open if the nerve is active. So you'll have people with a stroke that have a catheter because we can't tell the valve to open. It's stuck closed like forever. The brain, we just can't open it. Like the master control switch is gone. So those people would have a catheter. So like I said, you would be amazed at how many people are out wandering in our community that are otherwise healthy, but they have a catheter because their valves aren't responding. Make sense? So if you're working in home health, you're probably going to be trained in, we're going to put this on at night while they're in bed and in the home, and we're going to change to this when we go to the grocery store and to church. Good? You'll be trained on that. All right, so if we're going to empty the bag, what do we need to know? Well, there's a couple of different ways of emptying the bag, and I'm going to pass this bag around one more time now that you're familiar with it so that you can see this. There is a T valve, there is a clamp valve, and there is a twist valve. Now, the twist valve is usually on leg bags, but the T valve is the one we're going to use for the state exam. Clamp valves are also used occasionally. They're not as common as they used to be. This really has kind of become the industry standard. This is the one that I have here. So a T valve, Jake, I'm going to need close-ups. All right, let me explain to you how a T valve works. Get this out of the way a little bit. Okay, so down here is our valve. It lives in a little house, a little pouch. To remove it from its pouch, we just simply pull it down. Now it is outside of its house, which means it is at risk. So I need to open this valve. So if you look at this, if I look inside, you can see that valve is closed. You guys see how that valve is closed? You can see just to the side, right here, you can see, right here, you can see the hole. So in order to open this valve, I need to slide this T so that that hole lines up with this tube. So I'm going to slide it. There we go. And now it's open. There we go. Can you see? See how it's open? So now we're going to empty it. Empty. Put it into our cup. When we're done, we're going to close this valve. And I want to make sure it's closed because if I leave it open, pathogens can get right in. So we have to close it. Now, notice when I did that, when I opened it and when I closed it, I did not touch down here. This part of the valve or of the port cannot be touched by anything, not your hands, not the gloves, not the container, not the bag, nothing. Nothing touches this end of the port ever. It would be much easier to do this. I'd have more leverage. It would be way easier to do that. But that contaminates that end of the port. So everything that a CNA does is on this end of the port, never this end. Good? Questions? Now, when I go to put it back in its house, I can't let that end of the port touch anything. So I can't do something like this. I need to take that in and very carefully, very deliberately put it right into its home. You guys see that? Good? Okay, thank you, Jake. I'll pass this around so you can see how a T-valve works. This is the one that we're most likely to use on the state exam. All right. Remember that CNAs have to have additional training to change, separate these two pieces. This is a frequently missed area of the state exam. A lot of students, way more than I'm comfortable with, will separate these two pieces and take this entire bag of Simply over to the bathroom to empty it. You're leaving an open straw that's going to urinate everywhere. Because remember, kidneys produce urine 24 hours a day, drip, 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 which means there's a constant stream of urine going through here, drip, drip, drip. So we're getting drips everywhere. But also, we're leaving it open for pathogens. That's no good in a pathogen-rich environment. It's actually quite scary. Okay. So to open the T-valve, we're going to use the button on the side, slide it open, empty our urine, and then close it again. Closing is very important, but don't let the end of that port touch anything. Very important. Return it to its little house without letting it touch anything. When you're emptying the bag, we're going to put the graduate container on a barrier on the floor, not on the table. There's two skills where we don't put the barrier on the table. There's urinary drainage bag. Anybody remember what the other one was? Not bedpan. Where there's another skill where the barrier goes on the floor.
Oh, the foot care.
Foot care, that's right. So two skills, the barrier goes on the floor. So the biggest thing is don't let that port touch anything. Yes, I have 5 slides on this because it is that important. All right, so now we've got our urine emptied into our cup. We've closed our valve. We put it back into its house. Now we have to measure. And measuring follows a very specific protocol. So we're going to use this. This is a triangular, because it's a triangle, graduate, because it has markings, container. The urine goes in this. And the markings are going to help us measure. But we have to measure on a barrier, on a flat surface, at eye level. All 3 of these are on the same checkpoint. So if you measure this on a flat surface eye level, but you didn't put it on a barrier, you didn't get credit. All 3 of these have to be met. On a barrier, on a flat surface, at eye level. Please do not ever do this. Oh, I think it's never put urine above your face, ever. On a barrier, on a flat surface, and then you get down at eye level to read it. Now let's talk about these markings. We are going to measure to the nearest line. And in order to understand that, we have to learn the lines. So do we measure in ounces or cc's? Why? Easy answer. Easy. What's our easy answer? Care plan says. Yeah, easy answer. Care plan says. If you remember the care plan that I read to you, it said record output in mLs or cc's on the intake and output form. So are we going to use the ounces side? We're going to use the cc side. All right. So if you're looking at these numbers, you'll see we have 50, 100, 150, 200, 250, 300, 350, 400, 450, 500. The lines in between are your 25s. So if I have this line for 350 and this line for 400, the one in between is going to be 375. We are going to measure to the nearest line. Doesn't matter whether it's up or down. Nearest line. So if you're looking at this urine is right here. What number is that? So how much urine? 450. That's it. This is 450 cc's of urine. Where are we going to dump this? Should we dump it in the sink? Please don't dump it in the sink. For the test, this is water that has been tinted yellow. And it will be tinted yellow to make it easy to read. Because if I put clear water in here, you're not going to be able to read it. It's going to be hard to see. So we do tint it yellow for the test.
And since it's water, or well, we'll think it's urine, so we'll empty it in the.
Always put it in the toilet. Yep. Now, when I show you this video, you'll actually be able to measure with me. Okay. So we're going to document this at the end of our skill. So we do our closing, we wash our hands, and then we document. This is our intake and output sheet. Please make sure you are in the output section. Time, if you don't know military time and you put regular time, you must put AM or PM. Learn military time. Most places use it. I have a whole lesson in the book on military time for you. We're going to write down urine because that's what it is. You always have to declare what the output was. And there's lots of stuff that can come out of a human body, guys. Way more than just urine. You've got emesis, vomit. You've got wound drainage. You have blood. Right? There's a lot there. You've got diarrhea. There's lots of stuff that can come out of a human body. Do not assume that it's just urine. So you have to declare it. We're going to write the amount of output, 450 cc's, and then your initials. And then after we document, we wash our hands. So remember our care plan says empty the resident's urinary drainage bag into a graduate container. Let me pass that around for you guys to look at. Here you go. Yes. Yes. And we have those in our practice kits. So if you purchase a practice kit, there is a drainage bag in there. And there's a urinary graduate container as well as a bedpan. So all the skills that we learned today, the supplies for are in the practice kit. So we're going to record the output in mLs or cc's on the intake and output form. So let's look at our principles and apply them. Oh, I'm sorry. Let's go through step by step real quick this particular skill. So we're going to put a barrier on the floor, position the cup on the barrier under the bag. We're going to empty the bag, not letting the end of the port touch anything. We're going to close the bag, or I'm sorry, close the port when we're done and put it back into its house. We're going to cover the container as we travel. Remember, we can't take an open container of urine anywhere. So we're going to use that barrier on the floor, wrap it around our container, and take it to the bathroom. That's the same barrier we're going to use to put the container on to measure, because remember, we have to be on a barrier. So we're going to set it down on the lid of the toilet. We're going to measure on a barrier, on a flat surface, at eye level, and then we'll empty the container into the toilet. You're going to rinse the container and store it the way we rinse and store everything else. We're going to check to make sure the bag is not on the floor, not kinked. Everything is good. And then we're going to do our closing, wash our hands, document, and then wash our hands again. Now, let's take these principles, apply them to this checklist, and get 100%. We're going to follow the care plan. We're going to do our opening. We're going to wear gloves. Yes, we are. It's urine. We're going to use a barrier, this time on the floor. We're going to clean our basin like we clean everything else. We're going to do our skill-specific steps, and there's quite a few for this one. And we're going to do our closing. Please remember that this care plan is only for this patient. Nobody else. Nobody else. Every patient will have a different care plan. All right, so we're going to watch these two videos, one right after the other, and then the rest of the class will be practice. Not as much practice as I wanted to give you. I'm sorry. We had a lot to talk about, apparently. Good afternoon, Mrs. Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I'd like to perform catheter care. Is that okay? Okay, I'm going to close your curtain for privacy, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I can get my clean supplies. We're going to place a barrier on the table with the absorbent side facing up. This gives us a clean area for our clean supplies. And for this skill, we're going to need one underpad. We're going to need a towel, 4 washcloths, 1, 2, 3, 4. We're going to need a privacy blanket. We'll bring this over to the patient area. And I'm going to need a basin and soap. And a set of gloves. All right, Miss Jones, I'm just going to fill your basin. I'll be right back. To fill the basin, I'm going to use a paper towel to turn the faucet on because my hands are clean. I'll use my wrist to feel the water temperature. It should feel warm, not hot, not cold, just warm. And we'll fill the basin about a quarter of the way full. Mrs. Jones, would you like to check the water temperature? It's good? Wonderful. Okay. I'm going to place this privacy blanket over you, and this is going to help keep you warm and provide privacy as we do this skill. So I'll lay the privacy blanket over the sheet without snapping it or shaking it, and then pull the sheet down to about your waist. I'll put the washcloths in the basin. That way they get warm. And I'm going to prepare the underpad to go under the patient. I'll open it up. I'm going to hold it up lengthwise with the absorbent side facing me, and I'll roll it all the way to the end. Now I can put my gloves on. Okay, Miss Jones, we're going to place an underpad under you to keep your sheets dry while we do this skill. So I'm going to place an underpad on the bed. And in just a moment, I'm going to ask you to scoot toward me. I'm going to roll you on your side, and then we'll spread that underpad out. So on the count of 3, go ahead and scoot toward me. 1, 2, 3. Thank you. And now I'm going to roll you on your side. 1, 2, 3. And as I roll the patient, I want to be careful not to put any stress on this catheter or the tubing. You don't want it pulling tight. So I'm going to unroll the chucks underneath the patient and tuck it under her hip. Miss Jones, come on back and scoot to the middle of the bed, please. Okay, Miss Jones, we're going to repeat the process. Go ahead and scoot toward me. And we're going to roll you onto your left side. 1, 2, 3. And I'll smooth that chucks out underneath the patient. Come on back onto your back. And then scoot to the middle. Now we can begin the cleaning. Ms. Jones, I'm going to expose you. I'll make this as brief as possible. But please let me know if you're uncomfortable in any way. I'm going to roll the privacy blanket, making sure that I get the gown inside the blanket as I roll it. But I don't want to grab that catheter as I'm rolling the blanket. So you want to be very gentle with this process. This is going to expose the peri area. And then I'll place a towel over the upper thighs and make sure that the catheter tubing is on the towel. This is to help minimize exposure, increase comfort, and gives a place to put the catheter while we're cleaning it. Now I'm ready to start cleaning. I'm going to take my first washcloth, wring it out, and I'm going to soap 5 corners. 1, 2, 3, 4, 5. I'm going to hold the catheter out of the way, retract her labia, and then wipe down the center, top to bottom, and then move away and fold that leaf. The second leaf will wash the outside of the labia, top to bottom. We'll fold that leaf over. This is going in one direction only, top to bottom. This third leaf is going to wash the other side of the labia, top to bottom. We'll fold that over. The fourth leaf will wash the skin fold between the leg and the groin, top to bottom. We'll fold that over. The last leaf will wash the skin fold on this side, top to bottom. Now we'll set that aside on the barrier. And whatever we wash, we rinse. So we're going to wring that washcloth out really well. Hold it using the leaves method. I'll hold the catheter out of the way and open the labia and rinse down the center one direction, top to bottom. We'll fold that over. We'll rinse the outside of the labia, top to bottom, fold that over. The other outside of the labia, top to bottom, fold that over. This is going to rinse the skin fold. Fold that over, rinse the skin fold. We'll set that aside. Now we're going to clean the tubing. So I'll get washcloth number 3, wring it out really well. Hold it using the leaves method. And I'm going to soak 4 leaves. 1, 2, 3, 4. I'm going to hold the catheter where it exits the body so it doesn't pull on the inside. Wrap the washcloth around the catheter and wipe away from the body. We're going to fold that over and repeat 3 times. Hold the catheter, wipe the washcloth around, and move away from the body. 2, 3, changing the leaf for each stroke, and 4. We'll set this aside. Whatever we wash, we rinse. I'm going to wring the rinsing washcloth out thoroughly. Hold it in the diamond shape in my hands. Hold the catheter where it exits the body. Wipe the washcloth around and rinse going down the catheter. We'll fold that leaf. Rinse 2. Fold that leaf. Rinse 3. Fold that leaf. And rinse 4. We'll set that aside. Whatever we rinse, we dry. So we'll dry the peri area top to bottom and the catheter tubing. We can remove the towel, set it on the table, and we're going to unroll the privacy blanket, trying to be careful not to touch that gown with your soiled gloves, and we'll cover the patient up. Mrs. Jones, can I get you to scoot toward me, and I'm going to remove the pad that's under you. Go ahead and scoot toward me, and on the count of 3, you're going to roll up. 1, 2, 3. I will roll the soiled chucks toward the patient and tuck it underneath her hip. Come on back, Miss Jones. When I'm moving Mrs. Jones, because my gloves are soiled, I'm only touching the outside of the privacy blanket. Mrs. Jones, scoot to the middle of the bed, please. And now we can remove your chucks. If you can scoot toward me, again, my soiled gloves are only going to touch the outside of the blanket. And then you're going to roll up on your side, 1, 2, 3. And I'll remove that chucks from under the patient. Come on back onto your back. And then if you can scoot to the middle. Thank you. I'm going to go dispose of this. Okay, Mrs. Jones, you're covered. You're safely in the middle of the bed. I'm going to go dispose of your linens and clean your basin. I'll be right back. These items will go in dirty linen. We're going to clean this basin the way we clean all basins. I'll bring the basin to the sink and we'll dispose of the water in the sink. Rinse the basin and then dispose of the rinse water into the sink as well. I'm going to set that down, disinfect it per facility policy, and then pick it up with a paper towel. I'm going to get a clean paper towel to dry the inside. I'm going to get a clean paper towel to dry the outside. And then one more for the drawer. On the way, we'll pick up the soap, place it in the basin, use the paper towel to open the middle drawer, pick up the lotion and put it in the basin, and then store the basin in the drawer. We'll close it with a paper towel and then throw those paper towels away. Now we can dispose of the barrier. This will go in the garbage. And I can remove my gloves. Okay, Ms. Jones, I'm going to remove your privacy blanket now. I want to check your tubing real quick just to make sure that it's not kinked and you're not lying on it. So it looks good. It's not near the floor. So I'll pull the sheet up over the privacy blanket. This ensures that you're always covered. And I'll remove the blanket as I do so. Want to make sure that the blanket is rolled into a ball so trailing edges don't contaminate other surfaces. We'll make sure that the sheet looks good. All right, Ms. Jones, just let me go dispose of this in dirty linen. I'll be right back. We'll adjust the sheet on this side. There you go. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Your bed is in the low position. Your environment is clean. Here's your call light. If you need anything at all, go ahead and press the red button. We'll be happy to come help. I'm going to open your curtain and return your overbed table to storage. Now I'll go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Good evening, Mrs. Jones. How are you today? Fantastic. I need to empty your urinary drainage bag. Is that okay? I'm going to close your curtain for privacy, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get my supplies. We're going to start with the chucks. This is going to go on the floor under the bag. We're going to place the barrier on the floor directly under the urinary drainage bag. So we'll unfold it and we'll place it under the bag with the absorbent side facing up. I'm going to go get a set of gloves. And we're going to get the graduate container out of the drawer. You need to make sure that you put your gloves on before you get the graduate container. We're going to place the container on the barrier directly underneath the bag. We use the emptying port to empty the bag. This is a T-valve. We slide it to the side to open the valve, and then we're going to empty the urine into the graduate container without letting that port touch anything. Once the bag is empty, we'll close the port and place it back in its little house. All right, Ms. Jones, I just want to check to make sure the tubing is coiled on the bed and you're not lying on it, and that it's not coiled near the floor either, where it could become a tripping hazard. Now, I can wrap the chucks around my graduate container for safe and secure transport to the bathroom. We're going to set it down on the lid of the bedside commode and unwrap it, turning the cup around so that we can read the amount of urine that's in the cup. We need to be at eye level. It needs to be on a flat surface and on a barrier. I'm going to throw the chucks away. Open the lid and the seat and dispose of the urine into the bedside commode. I'll rinse the cup and dispose of the rinse water into the bedside commode as well. We'll close that, set the graduate container down in the sink, and disinfect it per facility policy. I'll pick it up with a paper towel, dry the inside with a paper towel, throw that away, dry the outside with a paper towel, throw that away, and one more for the drawer. Okay, Miss Jones, I'm just going to return this to storage using a paper towel to open the drawer. And closing the drawer, we'll throw those paper towels away, and then I can remove my gloves. You take a peek at your tubing just one last time. Everything looks good. Are you comfortable, Mrs. Jones? Is there anything else I can get for you while I'm here? No? Would you like a magazine before I go? Your bed is in a low position. Your environment is clean. I'm going to open the curtain. Here's your call light. If you need anything at all, just press that red button. We'll be happy to come back and assist you. Thank you very much. I'm going to go wash my hands. After washing my hands, we'll document the amount of output on the documentation sheet provided by the evaluator. We're going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. And we want to make sure that we're documenting in the output section. After documenting, I'll wash my hands one final time. After washing my hands a final time, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. Okay. Remember that everything that you need to practice is in our practice kits. There's bedpans, wash basins, emesis basins, triangular graduate container, the urine bag, stuff for denture care, chucks, the gait belt, comes in a carrying bag, soap, lotion, everything there for you to be able to practice these skills anywhere that you choose. And through Wednesday, you guys will get a discounted rate. Homework tonight is chapter 10. It's a pretty easy chapter. It's short. It's basically employability skills, reporting requirements. We're going to go over some of that on Wednesday as well. So you're going to get an after-class wrap-up email. Please remember that the workplace personality quiz is linked in there. That's one that you're probably going to want to do. It just takes 5 minutes before you come to class on Wednesday to get the most out of Wednesday's class for you. We have a lot to cover on Wednesday about continuing education, renewal requirements, finding a job, because it's totally different in healthcare than any other industry. So we're going to talk about all of that. And we will take a class photo, and I will collect the yellow books. So please make sure you're bringing your yellow books back to class on Wednesday. Since we will be taking a class photo, please make sure that you are in your class t-shirts. Okay. Employers do look at those class photos, and they sometimes will reach out to people from our class and say, hey, we have an opening, and they'll invite you to apply. So, all right. And again, if you need the screenshot of this, here it is for you. Jake passed out your review sheet, so we're going to go ahead and sign off of online. Thank you so much for joining us. We appreciate it. Remember, tomorrow is the game show at 11 a.m. on Eastern on our YouTube channel. So join us if you can. It'll be on communication, and I'll give you the actual framework to be able to answer those questions correctly on the state exam the first time, every time. All right, we'll see you tomorrow. Until next time, happy caregiving.